Of welcoming our esteemed faculty for the subject ENT, a fantastic professional who is one of the most beloved faculty at TAMS. I welcome Dr. Deepak Arora. Dr. Deepak is a very dedicated professional. Dr. Deepak Arora graduated from St. GS Medical College, KM Hospital, Mumbai, and post-graduated from IGMC, Shimla. His proficiency in the field of ENT is not unknown to the medical world and is adept in performing numerous procedures. His crisp approach makes him a very popular faculty among students. I welcome Dr. Deepak Arora for his session. Over to you, sir.
Yes, very good evening. Is audio video fine? All the students? Very good evening, everyone. All the students, let us start with the ENT segment. I know you are taking efforts since morning. Now I will try my best. The one best thing we will do, we will not write anything. Yes, we will not write anything. All the students who are working hard with us since the beginning of this session in 2023, now enjoy the segment, how we revise the notes. And all the students, even if you are attending my lecture first time, just listen to my words. My promise to you, all the students, that these 3 hours will be more than sufficient for covering all the ENT MCQs. I know you are exhausted. Everything will be uploaded. No worries, beta. Everything will be uploaded. No need of writing anything. Next 3 hours, enjoy. Next 3 hours, just enjoy, beta. Clear? So we'll be starting this session. Now concentrate on the board. The first slide, we will be taking, very good evening everyone, we'll be taking from the segment of epistaxis, the most important topic. Yes, Dr. Pranjal, thanks for all the compliments. Just give me 1 minute, let me, yeah. So we'll start with the important topic of epistaxis. Ready for fast learning? Very good, that's it. Now, beta, all the students, I will advise you, respect all the teachers who are taking efforts since morning. They are working hard for you people only. So everything will be from this DVT segment, from these class notes. So just let us start with the segment. Now concentrate on the board. Here, start the game. Is audio video fine? Is audio video fine, beta? Everything? Is audio video fine? Yeah. The first slide is dedicated on epistaxis. Listen carefully. Game starts now. I promise, beta, these 3 hours will be memorable. Epistaxis, the most important topic of nose. Which are the important points? Revise with me, beta. Next 3 hours, revise with me. Sit in the classroom, sit at your home, listen to my words. All the students who are sitting in our classrooms or you're sitting at home, just listen to each every word, beta. Just listen to word. My promise, you're 10 MCQs. That's my responsibility. And you will WhatsApp me. Clear? So the first, blood supply. Just remember, blood supply. Anterior, this is a fast revision segment, beta. So all the important topics are being covered here. So anterior ethmoidal, posterior ethmoidal, branch of ophthalmic, internal carotid. Just revise these points. Anterior ethmoidal, posterior ethmoidal, branch of ophthalmic, branch of internal carotid. Sphenopalatine, greater palatine, they are branch of maxillary, which is branch of external carotid artery. So what we have learned, beta, just don't waste your time. Just concentrate, beta. Don't distract here and there. Focus your eyes on the board, because I am confident many top ranks are listening to me here. And just if you are going for getting your dream branch, work hard. Don't get distracted. Just focus. Internal carotid ethmoidal. Maxillary is you're giving sphenopalatine, greater palatine. What is worth remembering point? Sir, I want to remember only one point. I will remember sphenopalatine artery. SPA, sphenopalatine artery, is a artery of epistaxis. This is worth remembering point. Nose is supplied by internal as well as external carotid artery. True statement. I am giving all PYQs. Coming on the areas. Anterior epistaxis, more common. Posterior, less common. Anterior epistaxis, litus area, retrocolumnar area, retrocolumnar vein. These are anterior part. Anterior bleed is more common in children, young adult. Posterior is your old patients. What is the cause of anterior? Cause of anterior is your traumatic. Cause of posterior is hypertensive, or it can be spontaneous. Anterior is mild, posterior is severe. Can I make a multiple statement? Yes. Bleeding in 70-year-old male is easy to control. False statement. Examiner can make multiple statement from this table. Am I understandable? Next 3 hours, Veda, I will teach you how to focus on the keywords. We are not here. We are not born to do quantitative learning. We are born to do smart work. We are born to do qualitative learning. So I will not mug up 2-3 pages on anterior epistaxis, posterior epistaxis. Not at all, beta. I will just remember these 5 points on anterior and posterior. Again, anterior more common. Litters area retrocolumnar vein. Children, young adults, traumatic, and it is mild. That's it. Easy to control. Easy to control. Easy to control. Am I understandable? Posterior epistaxis, hypertensive. It is spontaneous, it is severe, it is more than 40. So we can make multiple statements. Then can I write one important method, Trotter's method? What is Trotter's method? What I am showing you, you should not do this. Whenever there is a epistaxis, never swallow the blood. Always spit out the blood. What is this known as Trotter's method? Damn student, Trotter's method, epistaxis. Trotter's tried. Sir, nasopharyngeal carcinoma. Trotter's tried nasopharyngeal carcinoma. Trotter's method, epistaxis. Sir, I can't afford reading epistaxis more than 30 seconds. Revise 2 points. Everyone, revise 2 points. What is Trotter's tried? Pinch the nose, spit out the blood. What is TELESPA? Transendoscopic ligation of sphenopalatine artery. Transendoscopic ligation of sphenopalatine artery. I want every student sitting with me make a promise in the chat box, but I will complete this session in 3 hours. You will complete this session in 30 minutes before 3rd March. Before NEET examination, you will complete this in 30 minutes, Veda. That is, I promise, I want from your side. And it is very much possible. Trotter's tried, TELESPA. Trotter's tried, TELESPA for epistaxis. What is TELESPA? Transendoscopic ligation of sphenopalatine artery. Beta, no arrows required. No arrow. Just concentrate. Focus, focus, focus on the board. Yes, everyone. Trotter's tried. Coming to the next slide. This year, I'm expecting one slide on an instrument. They will ask you which investigation is used for obstructed nasal cavity. I want to appreciate the severity of the obstruction. If I want to appreciate the severity of the obstruction, I will do rhinomanometry. Not more than this. Identify the instrument. It is rhinomanometry for obstruction in the nasal cavity. Which is the narrowest part? Everybody know narrowest part. Internal nasal valve, Lyman nasi. We bound this on our tips, but just basic funda. Obstructed area is your narrowest part, Lyman nasi. Rhinomanometry. Done. Coming to the next one. Its model air cell should be on your tips. The first slide, the focus your eyes. I am showing you most anterior agonisi. Most anterior agonisi. Most posterior is my anode cell. I want to teach you 3 cells from the anterior ith model. Which 3 cells, sir? One is your anteriormost. One is the largest. What is the largest? Can you appreciate this large? It is bulla ethmodalis. Bulla ethmodalis. Beta, audio absolutely fine from our side, beta. Bulla ethmodalis, largest air, but I will take your feedback. I will definitely make it more louder. Just concentrate. Now, Bulla ethmodalis, largest air cell. Beta, largest this agonisi. I have written. This is anteriormost. Bulla ethmodalis, largest. Bulla ethmodalis, largest. If I come with the most posterior, what is most posterior? Anode cell. Most posterior anode cell. And which cell is on the floor? On the floor, Haller cell. Beta, this is not the time to write. Nah. We will revise. We will revise in the class. Everyone, we will not write. Listen each and every word. Very few slides. There is something which is not written. Otherwise, everything is written on the slides. Revise with me. Beta, revise with me. Most anterior agonisi. I am repeating multiple times. Why to worry? Revise in the class here. Why to postpone? Agonisi. Most anterior. Largest bulla ethmodalis. Both are part of anterior ethmod. Only one cell, that is the most posterior cell. Can you appreciate most posterior cell? This is your anode. Otherwise, everything is in anterior ethmod. Haller in the anterior ethmod. Beta, this honestly teaching for last 20 years. Beta, this is the best way. Please follow it religiously. Next neet can be the last neet. So no if and but, no excuse, no time for writing. Last few days left, better revise and get some decent branch. Otherwise, this game is already very complex. Coming to the next segment. Anterior group of hair cell. I have written everything. Maxillary, antethmodal, frontal. What is the posterior? Posterior is sphenoid and posterior ethmoidal. Where they open. Maxillary, anterior, middle and frontal. They open in middle meatus. Very favorite question. Very favorite question. One of the students is asking for rhinomanometry beta for obstruction in the nose. If there is any obstruction in the nose, we appreciate rhinomanometry is the investigation. They will ask you rhinomanometry for obstruction in the nasal cavity. Why to take pressure of this word? Posterior group. Sphenoid sinus open in sphenoethmoidal recess and posterior ethmoid open in superior. This is you have to confident because neat people can ask you these points. In inicet, they have shown the sinus sphenoid, most posterior superior, and they ask you where it open. It open in sphenoethmoidal recess. Then narrowest part of the nasal cavity, one of the students is asking, beta, is the internal nasal valve, Lyman nasi. Lyman nasi. Beta, in the last spell, like we are playing a cricket match, we are in the last 5 over. We have to run at this speed. Take my word, as a brother, I am telling you, no if, no but, no excuse. This is a time to focus on the things. If you don't know internal nasal valve, leave it. We can't afford now. We can only afford basic keywords which are waiting for you in the examination hall. Yes, I will be louder. I will ask my team to increase the volume. Now concentrate. Which view? Broader view. This is Waters view. Waters view. Broader view. It is for maxillary sinus. It is for maxillary. Best view for maxillary. Just remember. Which view, which sinus cannot be visible? Always remember, posterior ethmoid cannot be visible. Posterior ethmoid. Revise with me. Just close your eyes, beta. Behave like a 10th standard student. Learn to focus. Listen to my word. Maxillary, best visible. Posterior ethmoid, not visible. These are 2 important points. 2 important. We will not write. We will imprint on the brain. Posterior ethmoid, not visible. Sir, a potential MCQ. On 3rd of March, I want to see sphenoid. What you will do? Sir, I will open the mouth of the patient. What is Waters view with open mouth? Pierce view. I am making you revise in the class only. Best for maxillary. Never for posterior ethmoid. For sphenoid, Pierce view. Waters view with open mouth. That's it. These are the 3 MCQs. Caudal's view. When I speak the word caudal, long face. Can you appreciate? This is a broad face. This is the long face. Caudal is a long face. You will not mug up what is given on the slide. You will mug up. It is best for frontal ethmoid. It is best for frontal ethmoid. I am making you revise. Waters 3 MCQs. Best for maxillary. Never for posterior ethmoid. What sphenoid is Pierce view. Caudal's view, open mouth, Pierce view. Caudal's view, quick slip of tongue. Caudal's view, best for frontal and ethmoid. Which is the best view? Best view is the Waters view with open mouth. That's it. Waters view with open mouth is the best view. Coming to the caudals, which view we can appreciate all the sinus, but not so nicely. But MCQ can be there on the lateral view, all the sinus visible. All the sinus visible. Very rarely we have one basal view. This is very old MCQ. What is basal view? Written on the board, submentovertical. Submentovertical. Which 3 sinus are visible? Always remember a mnemonic SPM, sphenoid, posterior ethmoid and maxillary. Let us revise in a fast mode. So maxillary, so 3 MCQs. Best for what is best for maxillary? Never for posterior ethmoid. Open mouth, sphenoid, Pierce view. This is the formula we have to make in the revision segment. The formulas I will adjust the mic, but I will take your feedback very sincerely. I will ask my team to increase the volume. Yes. Now is it fine? Please kindly update in the chat box. Is it fine now? Is it fine, beta? Is it fine? Now concentrate. Basal view, submentovertical. Beta, one of the students is writing the word words. No, beta, no, none of the classroom is word. Every classroom is best classroom, beta. Next 4 months, don't use any negative word, beta. If you want a rank, honestly, I'm telling you, don't use any negative word. It will only increase your negativity. That's it. Sphenoid, posterior ethmoid, maxillary. This is the order. This is the order of sinus on basal view. On basal view. Coming on the next segment. If there is any obstruction in the nose, if there is any obstruction in the nose, it is rhinolia closa. Make this concept. You will not mug up 10 long list of causes, differential diagnosis of rhinolia closa. Rhinolia closa. Nose is close. Rhinolia aperta. There is a aperture. Where is the aperture? Palate. There is a aperture in the palate. Therefore, air from the oral cavity go to the nose. So just remember this point. Any obstruction in the nose, rhinolia closa. Any opening in the palate, that is rhinolia aperta. Palate insufficiency, rhinolia aperta. Any obstruction is here, rhinolia closa. 2 MCQs. Any obstruction, rhinolia closa. Any opening, rhinolia aperta. That's it. Beta, please listen these words. I am taking efforts only for you people that you should get some decent rank. Clear? Coming to the next level. What is the pneumatization of sphenoid sinus? Focus your eyes on the board. Pneumatization. Sphenoid sinus is pneumatized. We have 3 points. Thanks for all the compliments, beta. Thanks for all the compliments. Concentrate on the board. Hamburger classification. Those students who have not read about pneumatization of sphenoid, no worries. I will make you revise. Hamburger classification. What is Hamburger classification? Very small pneumatization. This is very small. Then medium. Then full. If there is very less pneumatization, we call it as conchal. This is conchal. Medium size pneumatization, pre-cellar, and complete pneumatization, it reaches the cellar tertica cellar. Just remember 2 points. Very less pneumatization is conchal. This is conchal. Everything is given, beta. If you open the DVT book, everything is mentioned. No worries. Listen to my words. Revise it with me. This is conchal. C for conchal, C for children. Most common pneumatization in children. Sir, conchal is conchal. This is pre-cellar and this is cellar. Complete pneumatization. So examiner asks you, one second. Examiner if ask you which pneumatization is common in adult, you tell me. When it will be completely pneumatized, it will be common. So this is cellar. Cellar is common in adult. Conchal, children. Cellar is in adult. Therefore, I have written 86%. Most common pneumatization. Done. These are the important points for pneumatization. Coming on the endoscopy. One day before the examination, which are the 5 points should be on your tips? Revise with me, everyone. Most common complications. Sir, synecdoche formation. Which drug is beneficial? Sir, mitomycin C. Mitomycin C. If you cause any trauma, CSF rhinorrhea. What is the most common cause of CSF rhinorrhea? Sir, endoscopic trauma. Which is rare complication? Sir, retrobulbar hematoma. I have written AE one day before the examination. Retrobulbar hematoma is due to injury to anterior ethmoidal artery. Which endoscope are commonly used in nose? 30-degree endoscope is commonly used. 3rd March, be confident. This MCQ waiting for you. First pass. What is the first step? You will say, why you are so confident? Because this question come alternate year. Last year this question was not there. This year I am expecting one MCQ on endoscopy. First pass, we appreciate inferior meatus. In the second step, we appreciate superior meatus, supreme meatus, and anterior part of middle meatus. And third pass, we appreciate posterior part of middle meatus. Everyone listening to me across the country, revise 5 points. Endoscopy. But I know you're exhausted. I want you should not write. You should just listen, revise with me. Most common complications, sir, synecdoche formation. Which drug? Sir, mitomycin C. Most common cause of CSF rhinorrhea, sir, endoscopic trauma. Retrobulbar hematoma. Retrobulbar hematoma is due to injury to anterior ethmoidal. Which endoscope is best used? Sir, 30-degree. First step is equal to inferior meatus. Second step is equal to superior, supreme, anterior part of middle meatus. Third pass is posterior part of middle meatus. But 2002, 20 years back, when we appear for PG entrance examination, honestly, I'm telling you, we used to read very simple things beta. We can't afford quantitative. We can only afford 5 points. I can teach you endoscopy for 2-3 hours. We can't afford. We can afford this, from which they will pick one MCQ. So those students who are listening to me first time, or those students who couldn't study because of any unavoidable circumstances in the last 6 months, honest advice, please revise these points nicely beta. Clear? This is not the time to go into the depth of the topic. Sinusitis, which is an important point. Chronic sinusitis is more than 3 months. More than 3 months. 12 weeks is chronic, and just this point, chronic. And acute is less than 1 month, 4 weeks. Done. Which virus? Sir, rhinovirus. Sir, rhinovirus. Most common. Which bacteria? Ent. It is strepto. Commonly it is strepto. So from this slide, we have to learn 4 MCQs. Revise with me. Rhinovirus, beta. Rhinovirus. Revise with me in the class only. Revise in the class only, beta. Chronic, more than 3 months. Acute, 1 month. Virus, rhino, bacteria, strepto. That's it. They will pick one MCQ. Enjoy this concept. Last 2 months beta, this is a need of R, where we have to revise in such a mode. Fever, pus in the middle meatus is equal to sinusitis. I always teach, if you have attended my regular batch or T&D, I always teach the ENT in a physics mode. We have to write the formulas. Enjoy the formula. Fever plus pus in the middle meatus is a hallmark finding for sinusitis. Done. Office headache, maximum pain in the morning, minimum pain in the evening is frontal. F written, frontal. Not time to write complete frontal. We can write only one alphabet, F frontal. The word in my MCQ, if the word cheek is mentioned, the word dental is mentioned, the lower eyelid is mentioned, I am talking about maxillary. Revise with me. Cheek, dental, lower eyelid. So I will attempt maxillary. Root word, radix mentioned, dorsum mentioned, I will go for ethmoid. They will give you 6-line MCQ on sinusitis. Your eyes should be focused on these keywords. Occipital word mentioned, vertex mentioned, retroorbital, sphenoid. I have seen many faculties wasting time, whether it is vertex, whether it is occipital. Forget, they will not ask you. You are not here to do PhD of sinusitis. They will give you a word, occipital word or vertex in the MCQ, and you have to attempt sphenoid sinusitis. Last spell, this session of 3 hours of ENT beta, I am hitting on these basic points. Please concentrate on the keyword. Which are the 4 complications which are common in frontal? Mucocele, pyocele, osteomyelitis, fistula. All the orbital complication in ethmoid. This is the need of R, if you ask me. And if you ask me who is the best performer in the last NEET examination, was Dr. Pilar from DAMS Bhopal. You listen to his interview. Last NEET, his rank was 1.5 lakh, running behind unwanted quantitative recorded apps. This year, his rank is 411. You listen to his interview, you will understand what is the best performance. And it is last spell, we cannot afford more than this. Anybody who is affording more than this is going to lose the game. Revise with me. Fever, pus in the middle meatus of is equal to sinusitis. Office headache is equal to frontal. Cheek, dental, lower eyelid is equal to maxillary. I don't know anything about maxillary sinusitis, but my focus, cheek, dental, that is your lower eyelid, is maxillary. Root, radix, dorsum, ethmoid, occipital, vertex, retroorbital, sphenoid. YouTube half an hour video, yeah, this the faculty should not do. How can you waste half an hour of a student to decide whether it is occipital or vertex? Nobody is going to ask you. They will give you one keyword. You have to attempt sphenoid sinusitis. Mucocele, pyocele, osteomyelitis, fistula. It is which common? Frontal and orbital ethmoid. When you revise 5 times, you will reach a level where the magic will start happening. Which magic? One day before the NEET examination, I say, which are the 5 MCQs? Where answer will be 6 MCQs where you will attempt frontal sinus. You will say, sir, office headache, sir, frontal. Sir, mucocele, pyocele, osteomyelitis, fistula, sir, frontal. Sir, osteoma, frontal. These are the 6 points where you will attempt frontal. Again, I am repeating for you. Office headache, mucocele, pyocele, osteomyelitis, fistula, frontal. Osteoma, frontal. Orbital complication, always in ethmoid. One of the students is asking what is radix. Beta, radix is this root. Other name of root, we call it as radix. Clear? So these are the important complication of my sinusitis. Coming to the next level. Again, very nice slide. For the last 2 years, your inicet people, they are asking you which of the following is a minor criteria for allergic fungal rhinosinusitis. Why they are asking? They want that you should mug up this table. No, they want that you should focus on this point. Fungal culture is the minor while fungal smear is the major. This is a paradox. It should be other way around. Fungal culture, I will be coming to Dr. Himanshi Beta. Pots puffy, I will be coming in the malignancy part. I will not miss any point, I promise to you. Just enjoy. Fungal culture is the minor. Fungal smear is the major criteria. This is the basic point. If you want to mug up this table, last spell, only mug up one part. Either mug up minor or major. Don't try to mug up each and every point. We can't afford. Or if you can't mug up 5 or 6 finding, at least learn one important paradox. Fungal culture minor, fungal smear is a major. This is point coming again and again. Mucocele. How you will differentiate mucocele from piocele? One student opening the notes of nasal cavity. Second student is saying, yes sir, I have read in ear, otology, serous otitis media and ASOM. Serous otitis media, there is no fever, no congestion. ASOM, high grade fever, congestion, cartwheel appearance, we will discuss in detail. Same concept here, beta. Mucus in the paranasal sinus is equal to mucus in the middle ear. So mucocele is identical to your serous otitis media and piocele is identical to ASOM. So apply a concept like a 10th standard student. Sir, high grade fever, tenderness, I will go for piocele. No fever, no tenderness is mucocele. Beta, please, instead of writing this, asking whether DVT is enough or study the main notes, please listen to my words. At last, I will summarize each and every point. First, listen here. Don't waste time in writing in the chat box, beta. I just want focus your ears and eyes on the screen and listen each and every word. So, mucocele, piocele is clear. Next, mulberry-like mucosa. If examiner give you mulberry-like mucosa, I will attempt hypertrophic rhinitis. Mulberry-like mucosa, hypertrophic rhinitis. Remember this point. I will repeat again, beta. Mucocele is beta only mucus. Pus, piocele. So no fever, no congestion will be mucocele. High grade fever, congestion, tenderness will be piocele. No hi-fi things. Mulberry-like mucosa, hypertrophic rhinitis with the help of laser, or we can use cobalt technique to remove the hypertrophic area. Remember, hypertrophic rhinitis is equal to mulberry-like mucosa treatment laser. Absolutely yes. Absolutely yes. Yes, this is strawberry, but I have shown you that at least you should remember mulberry-like. Nice. Pick this my error. Okay. So coming to the next one, atrophic rhinitis. So one day before examination, what are the 3 things, minimum things? Atrophic rhinitis. Everyone, nice observation. Come with the nice come with a nice observation. Nice observation, come with a nice sleep. Always have a sound sleep. Concentrate on the board. Atrophic. Appreciate RO. Roomy cavity. When everything is atrophied, it will be roomy cavity. It will be roomy cavity. Which word? Sir, merciful anosmia. Merciful anosmia is equal to atrophic rhinitis. Merciful Klebsiella. Which bacteria is Klebsiella? It related with atrophic rhinitis, and one is rhinoscleroma. I will teach you in detail. I have given you images only for visuals. If they give you some visuals, you can go for atrophic rhinitis. Every corner is atrophied. Every corner is atrophied. Coming to the next level. Which are the drugs used for atrophic rhinitis? Streptomycin, tetracycline, we can use vitamin A. I have given you all the important points in the treatment part. Like even it is documented placental extract are beneficial. We are not using, but in the MCQ they can use this statement, especially in inicet. Which of the following is a true statement of placental extract beneficial? These are the important surgeries. Young's operation, complete closure. Modified Young's is partial closure. So these are the 2 important worth remembering point. No need of mugging up the whole list. Just remember Young's complete blockage and partial is modified. Done. Unilateral foul smelling nasal discharge. Revise with me. This is something MCQ expected. Unilateral foul smelling nasal discharge is equal to foreign body. Is equal to foreign body. But which investigation? Investigation of choice. Listen carefully. I feel you are listening to me for first time. Investigation of choice. Treatment of choice in nose is endoscopy. Always. Always endoscopy. So don't waste your time in writing investigation in every topic. Unilateral foul smelling nasal discharge is equal to foreign body. Just remember this point. Coming to the next one. Fractures. So nasal bone fracture. Which are the 5 points should be on your tips? Nasal bone fracture, revise with me, should be reduced immediately. Second line, if edema, reduce after 5 days. Closed reduction within 3 weeks. Open reduction after 3 weeks. Revise with me. Nasal fracture, reduce immediately. If edema, give anti-inflammatory, reduce after 5 days. Closed reduction within 3, open reduction after 3 weeks. That's it. This is something to do with nasal bone fracture. Coming to the next slide. I have two forceps. Ash forceps, Welsham forceps. Ash forceps is for my septum. Welsham forceps is for the lateral wall. Visuals, beta. Visuals. I am teaching 3 hours. You will revise in half an hour. Flip of the slides. Ash forceps for septum. Welsham forceps for lateral wall. Lateral wall. Lee-Ford classification. I am showing you Lee-Ford classification. Lee-Ford classification. Lee-Ford 1, Lee-Ford 2, Lee-Ford 3. Composition of nasal cleaning beta. Just remember alkaline solutions are used, but as such they will not make the MCQ. They have merciful anosmia word. They have roomy cavity. So MCQ will be on that segment. Lee-Ford classification. I have 5 MCQs with me. Revise with me. Lee-Ford 1 is low maxillary, trauma to the lower part of maxilla and palate. When there is a palate, floating palate, palate traumatized, and there is some bleeding spot over the palate, we call it as Gurin sign. Lee-Ford 2 is a pyramidal fracture. It is along the nasolabial fold. Lee-Ford 3, the cranium separated from the face. Craniofacial disjunction. Craniofacial disjunction. Revise with me with the 5 MCQs. Lee-Ford 1, low maxillary, floating palate, and Gurin sign. What is Gurin? There is bleeding spot over the palate. Bleeding spot over the palate. Lee-Ford 2 is pyramidal fracture. Lee-Ford 3, craniofacial disjunction. Done. I hope everything is clear. Which fracture is class 1 fracture? Is Chevalet fracture. Class 1 fracture is Chevalet, and class 2 is Jarjave fracture. Chevalet fracture, they are vertical fracture. See the visual. This is vertical fracture. This is trauma from the below. You will have vertical fracture only when the trauma is coming from below. This is horizontal fracture. You will get horizontal fracture when the trauma comes from front. Revise with me. This is from below, vertical. This is horizontal fracture. This is horizontal fracture. Clear? Chevalet and Jarjave fracture. I hope everything is clear. Mucormycosis, black over the nose is mucormycosis. Black over the ear is malignant otitis externa. Expected slide. Black on the nose, mucormycosis. Black over the ear is malignant otitis externa. What is the keyword? Everybody should tell me. Keyword will be diabetic patient. Diabetic patient. One of the students is asking me, okay, which patient will have CSF rhinorrhea? So beta, if you focus your eyes on Lee-Ford 1, 2 and 3, you will say, sir, except in Lee-Ford 1, every condition CSF can come in the nose, but maximum will be here. I am here to crack all the queries, beta. If any point comes in your mind, just raise. So this is CSF rhinorrhea in 3 and more than 2. 3 more than 2. Then I want to teach you which is the drug of mucormycosis. Everybody know liposomal amphotericin B. This mucormycosis, microbiology, medicine people will teach you, but I want to give you one point. It have special love for blood vessel. Special love for blood vessel. It block the blood vessel. So all the students listening to me, make a concept. Mucormycosis block the blood vessel. Therefore, there is no epistaxis, no bleeding. Once everything is necrose, there is no bleeding. I hope there is no need of writing all these points. Just learn. I have written all the keywords. Coming to the next one. Rhinoscleroma. Rhinoscleroma, again caused by Klebsiella. Anyone who can write in the yes, one of the students is asking me, basal cell. Beta, basal cell carcinoma will be invading the skin. I can't confuse basal cell carcinoma with black lesion necrotic. That is absolutely different. Beta. It will be easy. It will be rodent ulcer. Chevalier trauma coming from below, vertical fracture, Jarjavi front. Beta. Clear? Now, no epistaxis in late stage, last stage of mucormycosis when everything is necrose. Clear? Coming to the next one, very good, excellent. Which word is equal to rhinoscleroma? Woody nose. If the word woody is mentioned, I will go for rhinoscleroma. Very good, excellent, rhinoscleroma. Which are the important keywords? Miculi cell Russell bodies. Miculi cell Russell bodies are the important points. Clear? Miculi. These are the big macrophages. Russell body, eosinophil. Very good. Excellent. The speed at which now students are replying in the chat box, it means you people have revised nicely. In rhinoscleroma, I just want 3 MCQs. Carpenter glue. Revise with me. Carpenter glue. Foul smelling discharge. Foul smelling discharge will be in atrophic stage. Revise beta. And now neither ask me what is carpenter glue nor ask me atrophic, because this is not a time and they will not ask you. You are not going to write a prof exam. You are here to click. Carpenter glue is in which stage? Atrophic stage. Hebra nose is in which stage? So it is in granulomatous stage. And tapering of the nose is here cicatricial stage. These are the important stages. On this side, I have given you drug of choice like Klebsiella, streptomycin, tetracycline. Very old MCQ of PGI Chandigarh. Calesa resin is used for. It is used some in case of rhinoscleroma, and these are the important compounds we use for rhinoscleroma condition. Clear? Again, atrophic stage, Carpenter, Hebra nose, nodule over the nose, Hebra nose, granulomatous stage, and tapering, that is your cicatricial stage. Rhinospodiosis, 1 day before the examination. Rhinospodiosis, mulberry-like polyp, mulberry-like mucosa is hypertrophic rhinitis. Mulberry-like polyps, rhinospodiosis, caused by Rhinospodiosis sebarii. It was fungal but now protozoal infection. History of taking bath in the ponds. Treatment, surgery with cautery. Drug of choice, Dapsone. 1 day before the examination, your motive should be rhinoscleroma should be revised in 30 seconds. Again, Rhinospodiosis sebarii. History of taking bath in the ponds. Is a protozoal infection. Surgery followed by cautery. Dapsone is the drug of choice. Done. Found in Tamil Nadu. Very good, beta. Excellent. Very good. Very good. Clear? Like I have already mentioned, beta, drug of choice for mucormycosis. Coming back to the next segment. Apple jelly nodule. Apple jelly nodule. This one. What is the important site? Just remember, the most important site for this will be mucocutaneous junction. So if the examiners show you something here, that is apple jelly nodule. Even in dermatology, you will read all these basic points. I am showing you this slide visual. The most common site for apple jelly nodule at the mucocutaneous junction. Nasal polyps, beta. Important point. Nasal polyps, we are having 2 types. One is enteroconal, one is ethmoidal. Enteroconal, adolescent, 10 to 14 years. It is infection. They are single. They are unilateral. They are trilobe. 3 lobes are there. They grow posteriorly, backwards. Treatment will be always FES. Ethmoidal polyps. They are in the age of 20 to 40. Adult, allergic, multiple, bilateral, grape-like. They move forward. What is the treatment? First we give anti-allergic. Because allergy is a main factor, reoccurrence is seen. 1 day before the examination. Sir, ethmoidal polyps is equal to adult. allergic main cause, multiple, bilateral, grape-like, moving, coming out, forward. Anti-allergic first line, treatment phase. Revise with me. Enteroconal polyp, 1 day before the examination. Sir, 10 to 14 years. Sir, infection. They are single. They are unilateral. They are trilobe, 3 lobes, moving posteriorly. Treatment, surgery. No anti-allergic. Why? Allergy is not the fact. I hope you're getting this point. Clear? Coming to the next level. What I'm showing you, this is some swelling at the midpoint of your septum and the lateral wall. If there is a swelling at the midpoint of septum and the lateral wall, this is pyogenic granuloma. This is known as pregnancy nasal tumor. Pregnancy nasal tumor. Why we call it as pregnancy nasal tumor? It is commonly in pregnancy because of failure of oral contraceptive pills. 2 points. Which are the predisposing factor? Oral contraceptive pills and pregnancy. Done. These 2 points should be, it is a misnomer. Now the student is asking for this better image is given. This is ethmoidal polyp, multiple large grape-like polyps. If you get a single polyp, we go for ethmoidal polyps. Clear? Coming to the next one, absolutely right, beta. Conservative management, very good, very nice. Even this must be covered in gynae ops. Coming to the next slide, I want to teach you tumors. Everybody revise with me. I want to teach you 3 tumors on the septum. If the tumor is whitish, it is papilloma. Can you appreciate? No need of writing. Visuals. Observe. If it is white, it is papilloma. If it is dark brown, malignant melanoma. If it is reddish, capillary hemangioma. Revise with me, every student, revise with me. With a conservative management. Pyogenic granuloma will be, you touch your septum, you touch your lateral wall, somewhere in between these two. We will get, commonly it is somewhere in between septum and the lateral wall, midpoint. This slide very crucial. Anything on the septum, revise with me, 3 points. Red is capillary hemangioma, dark brown is malignant melanoma, and whitish is papilloma. This is something on the septum. These are the 3 important tumors. Revise with me again. White, papilloma. Dark brown, malignant melanoma. Reddish, capillary hemangioma. This is papilloma, which is on the septum. If I take it on the lateral wall, it becomes inverted papilloma. Revise this concept. It is on the lateral wall. Revise with me, beta. Papilloma is on the septum. Inverted papilloma is on the lateral wall. I have written all the other names of this inverted papilloma, Ringer's tumor, transitional cell papilloma. These are the important synonyms used for inverted papilloma because it is pre-malignant. But you need not to write anything, and these videos are with you till 3rd of March. And we want not to see this video after 3rd March. We should crack our examination. So don't take pressure, beta. This is the last session of the day. So I have deliberately make it very simple for you. Everything is written. Focus. Especially it is the students who have revised everything. This is a best revision for those students. Those students who couldn't study in the last few months, no worries, beta. No worries. There's not time we can touch any ENT book. We can't afford it. We have hardly 2 or 3 days left for ENT only. So just better revise this. Clear? Because it have high pre-malignant potential. It is known as squamous cell papilloma. One of the students, nice query. Rhinosporiosis against mucomycosis. But rhinosporiosis will be typical history. Patient taking in the pond, bath in the ponds. They will use the word mulberry-like polyp. They will use this word. Clear? Again, yes, I will. Now here comes the important game. Squamous cell carcinoma. Listen carefully. What is the important concept you should learn? Now stop writing. From the lateral wall, your inverted papilloma is coming. From the lateral wall, squamous cell carcinoma is coming. Inverted papilloma will not damage the wall of maxillary sinus, and squamous cell carcinoma will damage the wall. Remember this point. Listen this word, beta. Inverted papilloma coming from lateral wall, squamous cell carcinoma coming from lateral wall. What is the difference? it will damage the wall. Which I ask you, say, sir, I want to write. You don't write. You tell me. Inverted papilloma, squamous cell carcinoma. Be confident of your memory, beta. You have cracked your UG entrance exam, NEET, UG entrance. You enter in the medical college because you have used some logic, common sense in the 12th standard. Now what we are doing? Now we should mug up everything. Not possible, na? I am giving you two options. One is inverted papilloma. One is squamous cell carcinoma, which will damage the wall of the maxillary sinus. From the nose, enter the maxillary sinus, then damage. Why you are writing? Common sense in the examination hall, it will click, so malignancy will damage. So if the maxillary sinus is damaged, it will be squamous cell carcinoma. If the maxillary sinus is not damaged, it is your inverted papilloma. I am highlighting this point, beta. If you want to crack this NEET examination, we have to use the skill, common sense. But for the last 2-3 years, especially in the COVID era, we start reading everything. Okay? We will read everything. Then only it is possible to crack all the MCQs. Not practically possible. Use your common sense and behave. You used to behave in 11th standard, 12th standard. When you were very brainy students, last 4-5 years, something have happened. You have bombarded. And take my word, beta. Why many students, they are quitting in the second year, third year? Nobody, at our time, nobody used to quit. But now they are in second year. Why? Because they bombard themselves. Their first year is time, first or second time to adapt to the medical college. And they are 24/7 recorded apps. No, never do this blunders, beta. Just try to attend whatever you are attending live. You are attending me. You are interacting with me. You are enjoying the session. A time-bound game is there. So please play the time-bound game. Coming to the next segment. Which approach is used for nasal malignancy? I am giving you two approaches. One is lateral rhinotomy approach. Lateral rhinotomy approach. One student is writing honeymoon period. Better no. Second year patho micropharma are the basic sciences which decide your honeymoon and after post-graduation. So second year is not the honeymoon phase. They are the time, that is the time which decide your honeymoon destination. Am I understandable? If you are not studying in the second year, Mahabaleshwar will be your destination. If you study hard with dams in second year, Mauritius will be your destination. I hope you are getting the message. Lateral rhinotomy. Lateral rhinotomy is used for nasal malignancy. Weber-Ferguson. Focus your eyes on the board. Weber-Ferguson is for maxillary sinus. Weber-Ferguson is for maxillary sinus. Okay, but I will take 1 minute. I will arrange the volume segment because everybody is saying volume. I will just make some concentrate on the board. Just wait. Give me 1 minute. Is it audible? Is it audible? Is it audible now? Now is it audible? Now concentrate on the board. Everyone. One student is writing, Mahabaleshwar is very good. Beta, my MBBS was in Mumbai. I know Mahabaleshwar is very good, but Mauritius is much better. No? So we should have a dream of Mauritius. Coming back to the topic, lateral rhinotomy is here for nose. Lateral rhinotomy for nose. Weber-Ferguson for maxillary sinus. Weber-Ferguson for maxillary sinus. Clear? Beta, inverted papilloma, you are asking me to repeat. I have given all the important point, worth remembering point. Lateral nasal, lateral wall of the nose is the most common site. These are the two important incisions. Occurrence classification. What is occurrence, beta? Listen now, everyone, concentrate. If the tumor is below the line, is good prognosis. Tumor above the line, poor prognosis. Occurrence line. What is occurrence line? Line from medial canthus to angle of mandible. Mnemonic for you. Tumor line के नीचे बंदा नीचे, tumor line के ऊपर बंदा ऊपर. Below the line, good prognosis. Above the line, poor prognosis. Second classification, your Ladderman classification. Ladderman classification should be on your tips, beta. Ladderman classification. Ladderman classification. One of the students is asking me Moore's incision. Moore's incision is the other name of lateral rhinotomy only, beta. Lateral rhinotomy, Moore's incision. Weber-Ferguson for maxillary. This is occurrence classification. This is my Ladderman classification. We divide the nose into three parts, face into three parts: supra, meso, infra. Supra segment, meso segment, infra segment. Ladderman classification. Done. This is Ladderman classification. CSF rhinodia enjoy. But one day before examination, you should give 30 seconds to CSF rhinorrhea. Sir, most common cause, site, sir, cribriform plate. Most common cause, surgical trauma. What is the management? Wait and watch with IV antibiotics. What is the glucose concentration? 30 milligram per deciliter. Investigation of choice, electrophoresis. We will appreciate beta-2 transferrin. And what is the site of leakage? HRCT. Revise with me. CSF rhinorrhea. Revise beta. Revise in 30 seconds. Cribriform plate, most common site. Surgical trauma is the most common cause. Treatment, wait and watch with IV antibiotics. Glucose concentration more than 30 milligram per deciliter. Electrophoresis, beta-2 transferrin, HRCT is the investigation of choice. One of the students is asking about FMG is enough. Beta, FMG NEET examiner team is same. 20 years back, 10 years back, FMG exam was 10 times less difficult than NEET exam. Last two FMG examination, they are more difficult than NEET examination. So everything is now examiner is same. So it is more than sufficient. Beta, please don't ask this point again. Clear? It is sufficient. Again, CSF rhinorrhea. I am telling you why? Because CSF rhinorrhea MCQ is there on the 3rd of March. You have to attempt this point. What is the most common site? Sir, cribriform plate. Most common cause? Surgical trauma. What is the treatment? Sir, wait and watch with IV antibiotics. What is the glucose concentration? Sir, 30 milligram per deciliter. Sir, electrophoresis. What you see? Electrophoresis, beta-2 transferrin. HRCT is your site of lesion. Site of lesion. Site of lesion. Dr. Manika, I am repeating the statement only. Beta, 5 MCQs. Most common site, cribriform plate. Most common cause, endoscopic trauma. Treatment, wait and watch. 30 milligram per deciliter is a glucose concentration. Electrophoresis, beta-2 transferrin, HRCT, site of injury. Coming to the next level. The patient is very happy because he is saying, I am suffering from malignancy, not COVID. Few MCQs on the malignancy part. First MCQ. Everybody should reply. Every student should reply. Unilateral cervical lymphadenopathy. But why IV antibiotics in CSF rhinorrhea? It is because of to spread the avoid the spread of infection into the brain. Unilateral cervical lymphadenopathy. Again, the students are writing in the chat box. Investigation of choice, beta electrophoresis, on which we see beta-2 transferrin. Clear? Concentrate on the board. Unilateral cervical lymphadenopathy. Nasopharyngeal carcinoma. Epistaxis, young boy. Sir, angiofibroma. Sir, wood industry. It is your ethmoid adenocell carcinoma. Sir, nickel industry. Sir, maxillary cell carcinoma. Revise 4 points with me. Unilateral cervical lymphadenopathy, nasopharyngeal carcinoma, epistaxis, young boy, angiofibroma, wood industry, ethmoid adenocell carcinoma, nickel industry, maxillary squamous cell carcinoma. These are the important points, should be on your tips. From here, I am entering into the ear segment. Focus your eyes on the board. I am showing you a nice image of pinna. I have labeled all these structures. Just remember two worth remembering point. This one is your Simba concha beta. Focus your eyes. This area is your Simba concha. This is for mastoid tenderness. And keep your finger above the tragus. This area is incisura terminalis. That is for incision. Revise 2 points with me. Revise 2 points beta. Revise 2 points with me. One is Simba concha. Simba concha is equal to mastoid tenderness, and one is incisura terminalis, that is for giving a incision. What is the name of the incision? Is known as Lambert incision. Done. Coming to the next slide. These are the important highlighters on pinna. What is this? I am showing you a small sinus in front of pinna. What is this small sinus in front of pinna? Is preauricular sinus. Why this preauricular sinus is there? Because of incomplete fusion. Beta, I know few students are distracting in the chat box. Beta, it may be any motive can be there, but please, when we are discussing in such a nice way, every student across the country, those students who are saying something in the chat box, come to our Delhi, the session going on where the live more than 2,000 students sitting and enjoying, and take my word, beta, that's your choice, because motive can be anything. Just focus your eyes and don't distract those students who are enjoying. Pre-auricular sinus, incomplete fusion of hillocks, clear? In the beginning, I taught one thing: never ever say anything about a teacher. And I understand, never make a rule, because when you were born, they were doing MBBS, they were doing post-graduation. So just enjoy, respect, beta, and you will enjoy a lot. And take my words, last spell, whatever our all 19 faculty will teach you, this will be the game changer. Am I understandable? Clear? So just please focus on the slides. These are the important slides which they can ask you in visuals. They can ask you visuals, anotia, bat ear, microtia, cup ear, crypto. What do you mean by crypto? Crypto matlab hidden, some छुपा हुआ, lower part, hidden in the upper part, Clear? Coming to the next level, Lampert incision. I will repeat, beta. You keep your finger above tragus. Just keep your finger above tragus. This area, there is no cartilage, so it is best to give the incision. What I am showing you a normal tympanic membrane. Now this is the time, not the time to write the points. Observe, this is cone of light, this is handle of Malleus, cone of light, handle of Malleus. What I am showing you, reliable markers. Clear? These are the reliable markers of tympanic membrane. Then, yes, beta, we know. Now one of the student is writing the cause ke why. One student is writing something in the chat box. Beta, please focus on the board. Coming to the next one. This is normal. Everyone focus. This is normal. If the examiner use the word pulsatile, everybody should write in the chat box. If the word pulsatile word is mentioned, I will make a diagnosis of glomus tumor. This is pulsatile, glomus tumor. This is my blue tympanic membrane. So what is blue tympanic membrane? When you speak the word blue, you get a feel of glue. It is glue ear. And what is this? This is small blebs. These blebs are meningitis bullosa. We'll make the concept. This is normal. This is glomus tumor. The word pulsatile. This is blue tympanic membrane. This is my meningitis bullosa. Inflamed. Whenever you get some redness, inflamed area, it is meningitis bullosa. Coming to the next one. I am showing you this slide, epimesohypotympanum, beta. This is the widest portion. Mesotympanum narrowest. Just remember 2 points, which is widest, epitympanum, which is the narrowest, that is mesotympanum. Clear? Epitympanum, mesotympanum. One student asking, investigation of choice for CSF leak. Investigation of choice, beta, is your electrophoresis. But if examiner asks you for site of leakage, that is HRCT. Revise, beta, epitympanum is widest. It is visible. This is meso, is the narrowest segment. Concentrate on the board. This is my Prusik space, beta. Focus your eyes on the Prusik space. This Prusik space is above Malleus. What is the importance of Prusik space? It is the most common site, earliest site for any pathology. Earliest site for any pathology is your Prusik space. Prusik space is most common site, earliest site for pathology. Then, coming to the next level, after learning all these basic points, most common site is your Prusik space. Coming to the next one. This is my Malleus. Make a golden rule. If any cartilage, if any bone is here, convex, it is Malleus. If any bone is concave, it is your incus. Done. If this is malleus, this is your incus. They can ask you two important joints. Which are the joints, beta? They can either ask you inquido-mallear. Focus your eyes on the board. This is inquido-mallear. This is inquido-stapedial. Inquido-mallear, inquido-stapedial joint. They will ask you what is inquido-stapedial? Ball and socket joint. Ball and socket joint. Now enjoy. This is ball and socket. Revise with me, beta, in the class. Ball and socket. What is this one? This is inquido-mallear saddle joint. This is your saddle joint. Clear? Done. Coming to the next one, saddle joint. Okay, just give me 1 minute. I'm resuming in next 1 minute. Just give me 1 minute. We will rectify this volume segment. Yes, is audio video fine? So we are talking about inquido-stapedial. Now concentrate on the board. Which joint we are talking about? This is inquido-stapedial. What is inquido-stapedial? Inquido-stapedial, focus your eyes on the board, is your ball and socket. Ball and socket, inquido-stapedial. And inquido-mallear, if they ask you inquido-mallear, we will go for saddle joint. It will be saddle joint. Is it fine now, beta? Everything is comfortable? Inquido-stapedial, ball and socket. Again, I will request better we should concentrate on the slide, on the concept. Now concentrate on the board. If examiner asks you, what is the most common site of trauma? Can you tell me which surface area is less? This surface area of inquido-stapedial joint is less. So it will be the common site. This area is a common site for trauma. This is common site for trauma. I hope everything is clear. This is trauma. Inquido-stapedial is trauma. If examiner asks you the most common site for necrosis, this is long process of incus, which is most common site for necrosis. That's it. Chalo, everyone revise 5 things with me. Inquido-stapedial, ball and socket. Inquido-mallear, saddle joint. Most common site for trauma. Most common site for trauma is inquido-stapedial joint. Most common site for necrosis, that is your long process. One of the student is asking me how to decide whether it is meningitis bullosa or whether it is serous otitis media. I'm writing a nice concept for you. Listen carefully, beta. If you see blebs, make a concept with me. If you see blebs and hearing loss is the first symptom, go for serous otitis media. I hope everything is clear now. Everything is clear. If hearing loss is the first symptom, serous otitis media. If pain is the first symptom, go for meningitis bullosa. I hope you will never forget. Now, everything is, because I want you should focus, you should listen, and you should click in the examination hall. But if you want, I should write the things, I will write. That's your, everything as per your choice. So these are the 5 important points. How to differentiate malleus incus? If it is convex, it is malleus. If it is a concave bone, it is incus. Simple, straightforward concept. Coming to the next one. I am showing you, concentrate on the board. I am showing you some important structure from anterior to posterior. Focus. This is my anterior. What is behind oval window is sinus tympani. Sinus tympani. Everybody comfortable now? Sinus tympani. But honestly, I always believe in smart learning. I never believe in writing the things in the last spell. If you're attending me in the month of, like, say, April, March, we can write. But now it's time to listen. Before the examination, listen these 3 hours here very comfortably. So sinus tympani. So what is the importance of sinus tympani? Just remember, sinus tympani is the nearest part. Because it is the nearest part, it is the most common site for reoccurrence. It is the most common site for residual disease. Right, the 2 point is the most common site for residual, most common site for reoccurrence. Sinus tympani. Done? No issue, beta. I will mix and match wherever something to write, I will write for you. Prusik space. Just remember, if examiner asks you the Prusik space is most common site. Prusik space is the most common, and this is your narrowest part is the most common site for residual or reoccurrence, which now the visuals, beta. No, beta, just concentrate. You focus your eyes. I will not miss anything. That's my promise. Now, most of the slide, everything is written. Chorda tympani, which now is moving between malleus incus. Chorda tympani. Now, focus your eyes on this slide. On this segment, I want to explain you the infection move from anterior to posterior. Infection always move from anterior to posterior. What I say in my lecture, infection from anterior to posterior, and ENT surgeon posterior to anterior. So infection move from ET tube into the middle ear into the mastoid. Which three words, everybody revise with me, which three words are worth remembering? What is the other name of epitympanum? The other name of epitympanum is attic. Which is the other name of mastoid? Other name of mastoid is antrum. Antrum is the other name of mastoid. And what is the communication known as? If you speak the word aretus, you get duct. Duct between middle ear and mastoid. Aretus is a duct between middle ear and mastoid. I will write for you. Those students who are feeling this confusion, most common site is Prussic space. Most common site is Prussic space. Where is the Prussic space? Is above malleus. On this slide, focus your eyes. Where will be the Prussic space? Prussic space will be here, above malleus. This is the most common site, earliest site. And which site is for reoccurrence? Reoccurrence is sinus tympani. Very simple. No hi-fi things. Coming to the next one. This is a anatomy with which I can revise the whole inner ear. Don't write anything because on the next slide I have given the right answer. Focus your eyes. We will start from here. Everyone, this is the best way to learn my inner ear. Cochlea. Number 1, cochlea. Revise with me. Number 1, cochlea. Number 2, cochlear nerve. What is number 3? Number 3 is a nerve coming from vestibule. Vestibular nerve. Revise with me the whole inner ear on a single slide. Number 1 is cochlea. Number 2 is cochlear nerve. Number 3, vestibular nerve. I take a pocket of cochlea. When I take a pocket of cochlea, I get this segment. I divide the cochlear segment into 3 parts. Lower part, scala tympani. Middle part, scala media. Number 5. Number 6, scala tympani. Beta, everything is written on the next slide. Just enjoy the anatomy with me. Cochlea, cochlear nerve, vestibular nerve, scala tympani, scala media, scala vestibula. What is the importance of scala tympani? Sir, cochlear implant is kept. What is number 7? Sir, number 7 is the upper membrane, Risner's membrane. What is the lower? Basilar membrane. What is the other name of Risner's? We can call it as vestibular membrane because scala vestibula is there above. What is number 9? 9 is semicircular canal. What is number 10? 10 is the duct of the canal. Semicircular canal duct. Number 11. Anyone who can write in the chat box, what is number 11? So number 11 is the bulge in the semicircular canal. What is bulge in the semicircular canal? Sir, ampulla. What is the importance of ampulla? Sir, sensory organ is there. What is number 12? Is utricle. Number 13 is my saccule. Best slide for revising whole inner ear. Number 1, cochlea. Number 2, cochlear nerve. Number 3, vestibular nerve. Number 4, scala tympani. Number 5, scala media. This is scala media. Number 6, focus your eyes, scala vestibula. Number 7, Risner's membrane. Number 8, basilar membrane. Number 9, semicircular canal. Number 10, semicircular canal duct. Number 11, ampulla. Number 12, utricle. This is utricle. Number 12, 13, saccule. Very simple. So on the next slide, what I have given, we have mentioned all these important points. Now, one day before the examination, which are the keywords? The keywords will be ampulla is equal to sensory organ. Ampulla is sensory organ. What is the other name of Risner's membrane? Basilar membrane. What is the importance of scala tympani? So 3rd March, you have to attempt scala tympani for which MCQ? Cochlear implant. where we keep the cochlear implant. Scala tympani, we keep the cochlear implant. I am writing with Dr. Aditya, I am writing everything now. I will not miss anything here. No issues, no worries. This is the complete slide for inner ear. On this slide, I will add few basic points for you people. Just remember one important concept. Outer hair cell. Outer hair cell is the right answer for important points. Autoacoustic emission. Sir, outer hair cell. Sir, which is damage in ototoxicity? Sir, outer hair cell. Noise-induced trauma, outer hair cell. So these are the three important points. Autocaustic emission, noise-induced trauma, outer hair cell. They are always more in number. They are always more in number. Beta, vestibular nerve, don't confuse. Vestibular nerve, Risner's membrane. Other name of Risner's membrane. Risner's membrane. Thanks for all the compliments, beta. Coming to the next level. Yes, now our favorite. Just try on the top of the page, 3rd March. Next 5 minutes, whatever we are studying, one MCQ expected in NEET examination. One graph within 25, one graph beyond 25. Sir, such a big airborne gap. Conductive deafness. Done. Airborne gap. Revise with me, beta. All you students listening to me for the first time. Airborne gap. Sir, we have not read audiometry. How to revise at this point of time? No worries, beta. No worries. Airborne gap. ABC. Airborne gap. Conductive deafness. The word itself is telling you airborne gap is a feature of conductive deafness. Sound sleep should be there. So AC, BC. Air conduction abnormal, bone conduction normal, airborne gap. Anyone who can make a diagnosis if both the graph are beyond 25. If both the graph are beyond 25, better make a diagnosis of sensory neural deafness. I am teaching as if you are a 10th standard student. I assume you have not touched audiometry. I want you should crack the NEET exam. I am teaching in that manner. And this video is with you, beta, with you only. If you miss something, no worries. After this, we will watch it again. Within 25 normal, one graph beyond, one graph within, conductive deafness, airborne gap. Revise with me. Both the graph beyond. Sir, it is sensory neural. Done. Now, identify this graph. There is a notch at 2000 hertz. What is this? This is my Carhart notch. 1 day before the examination. What you have to concentrate? Carhart notch is equal to bone conduction is on which frequency? Sir, 2000 hertz is which patient? Sir, otosclerosis. Sir, I don't know anything about Carhart notch. No worries, beta. Remember 4 points. Carhart notch is equal to bone conduction is equal to 2000 hertz is equal to otosclerosis 1 day before examination. This is need of R, beta. If time permit, I will show you. Many students, they concise. Last week I was in Bangalore. I have got one WhatsApp message from one of the girl. She concised the whole ENT in 12 pages and she WhatsApp me. This is the game of qualitative learning, beta. This need, you are having 19 subjects. Don't bombard yourself, beta. Just try to learn the basic points. So examiner will not ask you beyond this point. 2000, Carhart notch, otosclerosis. If the loss is at 4000, I will go with Boiler's notch, or it is known as acoustic dip. So what is the name of this notch? Noise-induced trauma, Boiler's notch. We call it as Boiler's notch. I will teach you with the word pregnancy, conductive. We will teach in otosclerosis. Now we are learning audiometry. We are working on audiometry. Boiler's notch. What is the guideline of WHO? WHO guideline is 85 decibel. What is the guideline of Indian Factory Act? It's 90 decibel. Patient should work 8 hours in a day, 5 days in a week. Number 85, lucky for ENT. In 85, now enjoy this segment. 1 day before the examination, sir, 85. 85, which MCQs? Sir, it is WHO guideline. Sir, it is hours in a day, days in a week, 8 hours in a day, 5 days in a week. 85 is success rate of Bell's palsy. Always remember, it is success rate of Bell's palsy. So these are 3 points. WHO, 8 hours in a day, 5 days in a week. then is Bell's palsy. It is Bell's palsy. Success rate. Clear? Coming to the next one. I am showing you two graphs. Can you tell me? Graph number 7, graph number 8. You people tell me what is the difference in the graph number 7 and 8. So graph number 7 is moving up, up, up. Rising curve. Meniere's disease. Graph number 8. So graph is coming down, down, down. So down sloping graph. So it is presbycusis. So in NEET examination, these two things are there. This is low frequency hearing loss. Low frequency hearing loss. This is high frequency hearing loss. That's it. Low frequency hearing loss, high frequency hearing loss. Dr. Prerna, beta, I will repeat, no issues, but I will recommend you just focus on the slides in a fast mode. Low frequency, high frequency hearing loss. Chalo. Because this is very important topic, I will revise for you again. If both the graph are within 25 is normal. If AC is beyond, BC is beyond within, and AC beyond, conductive deafness. This is known as ear-bone gap. Both the graph beyond 25 decibel, sensory neural. Maximum hearing loss at 2000, noise induced trauma. 2000 Carhart notch, 4000 noise induced trauma. 2000 Carhart notch, 4000 noise induced trauma. WHO 85, Indian Factory Act 90, and city life is maximum limit 45 decibel. 45 decibel. Clear? How to differentiate left from the right? Just remember, R for red, right side. Blue, left side. Low frequency, Meniere's. High frequency, presbycusis. I am coming on the tuning fork test. Rhenes in normal and in sensory neural, it is Rhenes positive. Air conduction is better than bone conduction. All the students, better be alert now. This is a very important concept coming. Weber is normal human being, not lateralized. In conductive, it is lateralized to worse ear, poor ear. Sensory neural deafness, it is lateralized to better ear. It is lateralized to better ear. Just remember this point. It is lateralized to better ear. Now, everyone comfortable with this Rhenes and Weber? Rhenes and Weber. One of the students is asking me to go slow. One student is asking me to go fast. That's no issue. I will somewhere make the balance. I have completed 9 graphs of PTA. I will revise again for you, beta. Both the graph within 25 normal. No worries, because we have 3 hours. So the students who feel that it should be very fast, no, we have to revise everything. So let us revise again, because MCQ have to be there. Both the graph within 25 normal. Both the graph beyond 25 sensory neural. AC beyond 25, BC within 25, it is your conductive. It is your conductive. Done. Now, maximum hearing loss at 2000 Hertz is your Carhart notch, and 4000 is noise-induced trauma, Boiler's notch. Then you have to learn few guidelines. WHO is equal to 85, Indian Factory Act is 90, city life is 85. Then I have given an extra keyword, Bell's palsy. Even in the Bell's palsy, the success rate will be 85%. 85%. Now the student is asking me, tuning fork explain. Honestly, beta, we should not discuss the detail of this segment, but if you want, very simple. I keep on pinna. If audible means amplification present. If audible on mastod, it means your ear conduction abnormal. So ear conduction abnormal means conductive deafness. Ear conduction normal means normal, sensory and neural. Now, which is ABC and Schaubeck? Absolute bone conduction test and Schaubeck test. These are tests of bone conduction, beta. Bone conduction. All the students, please listen, beta. Everyone, listen carefully. Schaubeck test and absolute bone conduction test, they are tests of bone conduction. Can I write a formula for you people? Bone conduction directly going to cochlea without amplification is equal to cochlear status or retrocochlear status. So whatever you are getting on the bone, it is a marker of cochlea. It gives you the status of cochlea. It is giving on retrocochlear segment. So absolute bone conduction test and Schaubeck test, they are test of bone conduction. But what is the difference? In absolute bone conduction test, we block the canal. Because we block the canal of, listen carefully, nice concept. Because we block the canal of patient as well as examiner. Patient and examiner, both canal is blocked, and then we check the bone conduction. Therefore, it is coming same as the examiner in conductive as well as normal. But in sensorineural, cochlea is gone, so bone conduction will come down. So bone conduction will come down in both the cases, whether it is absolute bone conduction or Schaubeck. Better listen carefully. This is slightly important concept. In sensorineural deafness, bone conduction will be reduced. Done. But in conductive deafness, if you block the canal, patient will have same as examiner in conductive deafness. But if examiner canal is not blocked and patient is suffering from conductive deafness, his bone conduction is lengthened. Why? Can you explain? Listen to my query. All the students who are master of this tuning fork test, can you tell me why Schaubeck test is lengthened in conductive deafness? Because air conduction is blocked. When the air conduction is blocked, patient have very nice perception via bone, because no disturbance is coming from outside. No disturbance. Listen to my words after the DVT session again. Why Schaubeck? The lengthen. Schaubeck is better, is lengthened in conductive deafness because external auditory canal block. But why it is same as examiner? Because in ABC, absolute bone conduction test, we block the canal of the examiner as well as patient. The examiner canal is blocked, but also he is suffering from conductive deafness. So the threshold is same. But in case of Schaubeck, it is lengthened. Little bit difficult, but if you listen to my words again, you will be able to crack this. Done. What is a golden rule? What is a golden rule to crack tuning fork test? I am writing in a capital letter. Everybody should revise this 5 times with me. Everyone speak out. Write the possibility of Renes and then rule out one with the help of Weber. This MCQ is expected. MCQ is expected. Write the possibility of Renes. Write the possibility of Renes and rule out one with the help of Weber. How to crack the numericals of tuning fork? Write the possibility of Renes, rule out one with the help of Weber. Can you tell me, any student? If Renes is, if Weber, write the possibility of Weber and rule out one with the help of Renes. This is the basic funda. Again, I am writing for you. We will write the possibility of Weber. What do you mean by this? Weber lateralized to right side. If Weber is lateralized to right side, 2 possibilities are there. It can be either right conductive or it can be left sensory. I hope you are getting my point. Weber lateralized to right side, 2 possibility, Weber conductive or right side, left side sensory. How you will rule out one? With the help of Renes. With the help of Renes. I am again writing this point. Write the possibility of Weber and rule out one with the help of Renes. This is the simplest way to crack the MCQ. Like Weber is lateralized to left side. Now if Weber is lateralized to left side, it means either it is left conductive or it is right sensory. Right sensory. And we have to rule out one with the help of Renes. We have to rule out one with the help of Renes. This concept is crystal clear, I hope. I am coming on conductive deafness investigation. What is investigation of choice for conductive deafness? Remember, tympanometry. This is what I am showing you, tympanometry. I am just focus your eyes on the board. This is your tympanometry. This is the normal graph. This graph is known as B tympanogram, also known as flat tympanogram. B tympanogram, also known as flat tympanogram. This is C tympanogram. It is in ET tube dysfunction. If there is a ET tube dysfunction, we will be getting C tympanogram. This graph is my ossicular damage. If ossicles are damaged, we get hypermobile. We get hypermobile graph, which is known as AD graph. AD graph. This is known as AD. And this is my AS graph. What is the differential diagnosis of AS? Autosclerosis, autofibrosis, tympanosclerosis, tympanofibrosis. Revise with me. Normal. This is B or flat. B in the perforation, flat in the fluid. This is ET tube dysfunction, C tympanogram. This is AS. This is AD graph. This is AD graph. Which is the highest level? What is the highest thing they can ask you in the examination? What is M-shaped tympanogram? Any student who can tell me what is M-shaped tympanogram? If they show you M-shape, examiner use a word double peak tympanogram. What is double peak tympanogram? M for myopathies. Just remember M-shaped tympanogram. If the examiner show you this is normal, instead of this, examiner show you M-shape. M-shape is myopathies. Never forget. What is the highest center for stapedial reflux? This is expected MCQ. Stapedial reflux. The highest center is superior olivary complex. It is superior olivary complex. Beta TF. TF is tympanofibrosis. Autosclerosis, autofibrosis, tympanosclerosis, tympanofibrosis. They are hypomobile. Hypomobile. Revise with me. What is the highest center for stapedial reflux? Olivary complex. At what decibel this is seen? This is seen at 70 decibel. So highest center is stapedial reflux, and high decibel at which it is seen, it is here 70 decibel. One of the student asking very nice question. Tympanic membrane retracted. So retraction is because of ET tube dysfunction. See tympanogram. Very good. Dr. Ashish replied. That is the beauty of this live discussion. It is C. It retracted. It will be C tympanogram. What is the investigation of choice for sensory deafness in electrocochleography? Beta, motive of DVT, visuals. I want to give you some visuals. Beta, we will discuss everything. One of the students is asking me, what is M-shaped tympanometrian cookie bite? Beta, I am here till this session is over. I will crack each and every point. Just have faith, listen to my word, enjoy, and get these words imprinted on your mind. This is electrocochleography, sensory deafness. What is the only drawback? It is invasive investigation. Invasive. What we see on electrocochleography, we see the ratio of SPAP. SPAP ratio. If the AP ratio is less than 0.3, is normal. If ratio is more than 0.45, it is abnormal. Ratio less than 0.3 normal, more than 0.45 abnormal. That acoustic reflux, beta, stapedial reflux. When the sound travels from cochlea to the brain get a signal that loud sound is coming. How brain stop? He stop by giving a signal to facial nerve. Facial nerve come down, it contract the stapedius muscle, and transmission stop. Transmission stop. Very simple, very simple. I hope you're getting my point. Coming to the next one, electrocochleography. Electrocochleography is investigation of choice for sensory deafness. What we see the ratio of SPAP. SPAP less than 0.3 normal, more than 0.45 abnormal. Beta, you are writing ADAS. We will discuss beta. Autosclerosis topic still pending. Autosclerosis topic still pending. So revise with me. What I am teaching first, revise that point. So electrocochleography is the investigation of choice for sensory deafness. What is the investigation of choice for neural deafness? Is my BERA. What is the other name of BERA? BERA. Brainstem evoke response audiometry. What is the other name? ABR. Auditory brainstem response. Beta, what is SPAP? Raghav, beta, SP submitting potential, AP action potential. Gurudev, DVT session, please. At least these are the small point. SPAP, no issues. If you have doubt, best part, we should always clear the doubt. Beta, if we take a break now, the whole rhythm will be break. It is better, we should continue. And this is the time we have to study harder, because next NEET can be the last NEET. So it is better, we should work hard. Just close your eyes and say, after NEET examination, government announced the next. So then you will say, na DVT, we should have not taken any break. So just concentrate on the board. Now, these are the important waves. Now, some students are asking query. That is a nice point. The student should impedance audiometry. Impedance audiometry is the combination of tympanometry and stapedial reflux, which will be covering in otosclerosis. Just wait for 5 minutes. Clear? So that is E. coli auditory pathway. Now, important. Now, enjoy. Everyone concentrate on the board. Bullet. 8 nerve. What is 8 nerve? Is the right answer. Anyone who can tell me 8 nerve is the right answer for which potential MCQ of NEET? It is for wave 1, wave 2, 8 nerve. Cochlear implant stimulates which part of the brain? 8 nerve, right? Cochlear implant stimulates 8 nerve. Brainstem implant stimulates. Brainstem implant stimulates cochlear nucleus. Revise with me. I am expecting one MCQ in this upcoming NEET examination. Cochlear implant stimulates which area of the brain? Sir, 8 nerve. Brainstem implant stimulate, sir, cochlear nucleus. Which is the largest wave? Sir, fifth wave is the largest wave. Which wave are the reliable waves? If examiner asks you about reliable waves, just remember reliable waves are wave 1, wave 3, wave 5. Revise with me. Wave 1, wave 3, wave 5. They are reliable waves, beta. Reliable waves. Done. Reliable waves. This is something to do with brainstem evoke response audiometry. What I'm showing you some screening procedure, autoacoustic emissions, OAE. This is something OAE. OAE, I have 4 MCQs for you. Which are the 4 MCQs? Concentrate on the board for OAE. 1 day, 1 month, 3 months and 6 months. What is 1 day? 1 day, concentrate on the board. 1 day is it should be done. It should be done, autoacoustic emission should be done on first day. It should be definitely done by 1 month. It should be combined with BARA by 3rd month, and treatment should be done. Treatment of the newborn should be done by 6 months. First, revise with me. One of the students is asking me what is ABR stand for? Auditory brainstem response. Auditory brainstem response. Done. Now revise important points. Autoacoustic emission is a screening procedure which is done in all the newborns. All the newborns, beta. All the newborns. We have to do OAE. Everyone revise with me. Autoacoustic emission should be done on which day? Should be done on first day of life. Should be definitely done by 1st month. Should be combined with BARA by 3rd month, but in which patient? High risk babies. Always remember, BARA should be done only in high risk babies. High risk babies. BARA should be done in high risk babies. And treatment should be done. I am repeating this statement. 6 MCQs out of 6. 1 will be there in the examination. Autoacoustic emission should be done in all newborns. On which day? Sir, first day. Should be definitely by 1st month. Should be combined with BARA. Which newborn? High risk baby. Admitted in ICU. Suffering from meningitis. By 3rd month. And treatment should be done by 6 months. Treatment should be done by 6 months. Done. What is OE? Autoacoustic emission is a marker of cochlea, beta. Your outer hair cell in the cochlea, they have autoacoustic emission. This is OAE. Done. Now, honestly, 1 day before the examination, what is my expectation from you people? Concentrate on the board. OAE negative. If OAE negative, this was the next expected MCQ. Listen carefully. If OAE negative, what are the 3 possibilities? 3 possibilities are either cochlea is absent. Beta, please understand this. What is the drawback of OE? Because this was last INICET MCQ, they can ask you in the NEET examination. It cannot, beta Aarti, I have not mentioned it cannot be done before 3 months. I have highlight, it should be done by maximum 3 months. You should do within first 3 months. Bara should be done. Orthoacoustic emission should be definitely done by first month. I have highlighted this point. Clear? Now concentrate on the board. Orthoacoustic emission, one of the best slide of this topic. Enjoy. Orthoacoustic emission absent, either cochlea is absent or cochlea is absent, cochlea is present but orthoacoustic absent. And the last possibility, the emission are blocked by middle ear pathology. So these are the three important options. So what to do? To differentiate cochlea is normal or cochlea is abnormal, we do electrocochleography. For middle ear, we do impedance audiometry. What is impedance audiometry? Sir, it is a combination of tympanometry plus orthoacoustic plus stapedial reflux. I am confident that many students are just focusing on the slide because this is one of the important expected MCQ for 3rd of March. Orthoacoustic emission absent, which is the next investigation should be done. Beta, I will complete everything on time. I will, because this is a time bound game. Examiner will not postpone the exam. Exam have to be on 3rd March. I will complete my session by 9. That's my promise. Focus, focus, focus. Orthoacoustic emission absent, electrocochleography or impedance audiometry. What is impedance? Combination of tympanometry plus stapedial reflux. Inspiration from Albert Einstein. Beta, have a sound sleep. Have a sound sleep in the next few days, beta. I can give my best performance in 16 hours if I have a sound sleep of 8 hours. Don't compromise your sleep cycle in next few days, beta. Clear? Coming back to the next segment. After learning all these points, most dangerous foreign body, yes, button battery. Most dangerous foreign body, button battery. What it can cause? Sir, facial nerve palsy. Most dangerous foreign body, button battery. Revise with me. Clear? Button battery, most dangerous foreign body. Coming to the next one. There is no drawback of OE, beta. There is no drawback of OAE. Clear? I will repeat once. Acoustic, yes. I should give this slide again. Orthoacoustic emission absent. 3 possibilities. Cochlea absent, or cochlea is present but emission are exceptionally absent. I'm wasting my time only because MCQ expected. Or it is middle ear pathology. So how to differentiate cochlea is present or cochlea is absent? We do electrocochleography. And impedance audiometry, always remember, it is for middle ear pathology. It is middle ear pathology. Done. Coming to the next level, concentrate on the board. 1 minute. Coming to the next level, concentrate on the board. Clear? This is most dangerous foreign body is your button battery. Just remember this point is button battery. One of the students is asking me explain serous otitis media. Beta, please give me few minutes. I will not miss anything. Cauliflower ear, boxer's ear, hematoma of the pinna, that is known as boxer's ears, cauliflower ear. Everything is written on the board. What is the treatment? Treatment is incision, drainage and pressure bandage. Incision, drainage, pressure bandage. What is this one? Anyone who can make a diagnosis? What is this one? Perichondritis. The external auditory canal. External auditory canal is absolutely normal. Pinna is inflamed. We call it as perichondritis. What is this one? Anyone who can make a diagnosis? This is frontal, which is known as localized otitis externa. Some students, they miss the MCQ. What is the cause of localized otitis externa? Because they don't know it is the other name of frontal. Concentrate. What is generalized otitis externa? This is generalized otitis externa, also known as diffuse otitis externa, tropical ear, Singapore ear, swimmer's ear, telephonic ear, all these are synonyms. Perichondritis, inflammation of pinna, external auditory canal known as localized otitis externa, and then we have generalized otitis externa, that are important synonyms. Now concentrate. Pseudomonas. Perichondritis caused by Pseudomonas. Fruncle. Perichondritis caused by Pseudomonas. What is the drug of choice? Sir, third generation cephalosporin. What is the fruncle? Fruncle is caused by staph and drug amoxicillin. Clear? So just remember this point. This slide very crucial. Beta, perichondritis, I'm repeating this thing, perichondritis and these conditions, they are caused by Pseudomonas. Only fruncle is caused by Staph aureus. It is caused by Staph aureus. Clear? Coming to the next one, what I'm showing you, black over the ear, granulation. Anyone who can make a diagnosis? Anyone who can make a diagnosis? Yes, but a cauliflower ear, there will be a small pocket like a cauliflower. Fluid collection. Perichondritis is pure inflammation. Nice query. This is a nice query. How to differentiate perichondritis with cauliflower ear? You will see small lobules full of blood. There will be inflamed area. This is malignant otitis externa. What is the keyword? Sir, keyword, diabetic patient. You are a damn student. Diabetic patient, MCQ from ear. Make a diagnosis of malignant otitis externa. MCQ from nose, I will make a diagnosis of mucormycosis. MCQ from oral cavity, we will make a diagnosis of Ludwig abscess. Generalized otitis externa is caused by Pseudomonas. On that slide, only fruncle was caused by Staph aureus. Clear? Malignant otitis externa. What is the presentation? Granulation and facial palsy. Which investigation is used for diagnosis? Remember, beta, because malignant otitis externa, again I will suggest you write this is the MCQ in your upcoming examination, because this question come alternate. So this malignant otitis externa, technetium 99 scan is for diagnosis. Gallium scan is for prognosis. My patient is very poor. He can't afford the scan. What we do? ESR. After how many weeks ESR comes down? It comes down after 2 weeks. Listen to my words. If ESR comes down after 2 weeks, it means my patient is responding. Which bacteria? Sir, malignant otitis externa, Pseudomonas. Therefore, what is the drug of choice? Drug of choice will be your cephalosporin. Always remember. What is the surgery of choice? Beta, they will mention big words. Modified radical mastectomy. Last word will be debridement. Go for debridement. 1 day before NEET examination. Granulation with facial palsy is equal to malignant otitis externa. Diagnosis, technetium. Prognosis, gallium. Lab investigation, ESR. Because it is Pseudomonas, go for third generation cephalosporin. Not responding, debridement. What I'm showing you a black spot, white spot. If it would have been white spot, I have labeled candidal infection. But now it is black spot as well as white spot. So I will label it as aspergillosis. Wet newspaper-like appearance. Just remember, wet newspaper-like appearance. Done. What is the treatment for staph? Beta Suman, amoxicillin is a drug of Staph aureus. Automycosis, aspergillosis, Niger. Many students, they get confused. When you write the word Niger, the Niger word itself is telling you I am in ear. Observation should be excellent. Aspergillosis niger, wet newspaper-like appearance. Coming to the next one. This was the slide. Maximum students were asking how to differentiate serous psoriasis media from meningitis bullosa. Pain. Beta, pain will be the first symptom, followed by hearing loss. Pain will be the first symptom, followed by hearing loss. If hearing loss is the first symptom, then pain. It is your serous otitis media. I hope everything is clear. Meningitis bullosa. It have multiple etiologies. Some books says it is viral. Some say mycoplasma. Some nowadays they are saying strepto. So depending on the etiology will treat the patient. What is this one? Concentrate on the board. A retracted tympanic membrane. How can you label it retracted? Sir, because normally I have observed only one malleus, but in this slide I can appreciate more than malleus. So if you appreciate more than one ossicle, we go for retracted tympanic membrane. Retracted tympanic membrane. Done. Just remember one point for your upcoming examination. Yes, for what BARA is done, one of the students is asking. BARA is done for ruling out neural deafness. Ruling out neural deafness. Clear? It is for neural deafness. Every student remember, when there is a retracted tympanic membrane, malleus become horizontal. Just remember this point. When the tympanic membrane is retracted, its malleus become horizontal. I hope everybody comfortable. What is the most common cause, earliest cause of middle ear pathology? Is ET tube dysfunction. Most common, earliest cause, ET tube dysfunction. Absolutely yes. How to differentiate a rupture with a retracted tympanic membrane? Beta, in a retracted tympanic, nice question. This is a nice query. Even inicet people can ask you. If you see multiple reflection points, only intact tympanic membrane reflect. Perforated tympanic membrane, no reflection. So if reflection is there, it is retracted tympanic membrane. Nice concept. What I'm showing you, there is some, anyone who can make a spot diagnosis? Any student who can make a spot diagnosis? Beta, look like perforated, but now you got the concept. Now you got the concept how to differentiate. Now you got the concept. Now you will never miss out. Any student who can make a diagnosis of this. What is this one? This is my, yes, any student, what is this going on? This is my, one second, osteoma formation. This is some osteomas? No. Yes, I'm giving you a clue. Patient is swimming. Patient is cycling. Patient is surfing on the beaches. What I'm showing you, it is osteoma formation. This osteoma can be unilateral, bilateral. If it is bilateral, we call it as exosteosis. And what is the other name of exosteosis? Surfer ear. Revise with me. Swimming, cycling, surfing give rise to osteoma. Osteoma can be of two types. It can be unilateral, bilateral. Unilateral, it is osteoma. Bilateral, exosteosis is known as surfer ear. Exosteosis known as surfer ear. What is the treatment? The treatment will be surgical excision. We will do surgical excision. Clear? Coming to the next slide, I am showing you keratosis obtrans. Make a concept. This is chalky white mass. Everyone, this flow chart should be on your tips. If the word chalky white mass is equal to cholesterol, is equal to squamous debris. If there is, consider, if chalky, yes, absolutely, beta, swimmers, yes, absolutely, yes. If there is a chalky white mass, it is squamous debris. In the middle ear, it is always cholestroma, but in the external ear, it can be cholestroma, it can be growth abnormality. This flow chart is very important. Which growth abnormality? So keratosis obtrans. It is a less chance. In keratosis obtrans, there will be no necrosis. Cholestroma, necrosis will be present. This we differentiate. Clear? What is the treatment? We have to go for keratolytic agents. What is the age of distribution? You tell me, is a growth abnormality, so it will be young age, 5 to 20 years. It is bilateral or unilateral phenomena? Bilateral phenomena. So worth remembering point for keratosis obtrans, growth abnormality, young age, bilateral phenomena. Bilateral phenomena. Clear? Clear? Bilateral phenomena. Growth abnormality, age of distribution is 5 to 20 years. Which point you want me to repeat? This one. Listen carefully. Beta, if there is a chalky white mass, If there is a chalky white mass, always suspect squamous debris. In the middle ear, it is always cholestoma. Why? Because middle ear lining is columnar epithelium. But in the external ear, it can be cholestoma, it can be growth abnormality. If there is a necrosis present, it is cholestoma. No necrosis is a growth abnormality. I'm repeating this point because some students are finding difficulty in this chalky. Those who are listening to me first time, I'm explaining. If there is a chalky white mass in the middle ear, that is cholestoma. In the external ear, it can be cholestoma, it can be growth abnormality. Coming to the next segment, what I'm showing you, traumatic perforation. What is the beauty of traumatic perforation? They heal of its own. Wait and watch. Beta, important slide. Dr. Kaushal, beta, just boost up your potential. Just take. We already 2/3 time is over. Last 1/3 is left. Stretch yourself. If we will not take the break, beta, agar aaj hum break nahi lenge and we complete the whole ENT, I promise you, after 9 o'clock now you will get a nice confidence that yes, we can do. But somewhere if we take the break, if we give up, somewhere in the after the session you will say, मैंने बीच में I have taken the break. So I will recommend, even it is difficult for me to go in this each and every point in a fast mode on these 3 hours. It is difficult for you, but we have to do because we are working in last spell. So please stretch yourself, beta. You have unlimited potential. Just use that potential. Clear? Traumatic perforation. Wait and watch. Every student listening to me, close your eyes. They will write one statement. Antibiotic eardrop should be used. No, antibiotic eardrop should not be used. Why? If we have to keep the ear dry. We have to keep the ear dry. If you will put any drop, healing will not occur. Healing will not occur. Clear? Coming, beta, concentrate on this slide. This is multiple perforation. Which word is multiple perforation? Multiple perforation is TB ear. Multiple perforation is your TB ear. Multiple perforation is TB ear. Tuberculosis, TB ear. And then multiple perforation. If now this is a very important slide. There is small blebs over the tympanic membrane. There are small blebs over the tympanic membrane. There is no fever, no congestion. Write with me. No congestion, no fever. The first symptom is hearing loss. Then the next symptom is pain. If the first symptom come hearing loss, then pain, we label it as serous otitis media. No congestion, no fever, we label the patient as glue ear, serous otitis media. What is the other name? Other name is secretory otitis media. We call it as secretory otitis media. Glue ear, effusion. What is the treatment? Treatment will go for myringotomy. If the patient is not responding with myringotomy, we go for grommet. After 3 months. So this is an important slide for serous otitis media. I have highlighted all the points. No fever, no congestion, known as glue ear, serous otitis media. Treatment, myringotomy with grommet after 3 months. What I am showing you now, I am showing you red tympanic membrane. What is this red tympanic membrane? This is my ASOM, acute suppurative otitis media. What will be the important point? High grade fever. Cartwheel appearance. Cartwheel appearance is seen in which stage? Stage of pre-suppuration. Just worth remembering point, pre-suppuration. Very good, beta. Excellent. One of the student is writing in the chat box, grommet means serous otitis media and Meniere's. Absolutely yes. We use in Meniere's, we use in serous otitis media. Done. Lighthouse sign, stage of suppuration. Lighthouse sign, stage of suppuration. Yes, beta, we give a very short course. Clear? Lighthouse sign is stage of suppuration. What is the important concept? In serous otitis media, we give anterior-inferior incision. In ASOM, we give posterior-inferior incision. Posterior-inferior incision. Always remember. Clear? Crystal clear concept. We never use grommet. Here, grommet is not used, beta. In ASOM, we never use grommet. Clear? Now, coming to this slide. Very nice slide. The damage, if you appreciate, damage is in the lower part. When the damage is in the lower part, we label it as safe ear. We call it as my patient is suffering from safe ear. If the disease is in the upper part, we will call it as unsafe ear. Lower part safe, above unsafe ear. Better treatment of ASM is myringotomy, a big incision in the posterior inferior. Now listen this concept, beta. Listen this concept. If there is a disease in the lower part, we call it as safe ear. This patient have perfuse discharge. And there will be none of the 10 words. I will be giving you 10 words. Out of those 10 words, nothing will be there. We will label the patient as tubotympanic ear. And what is the treatment of this patient? Treatment of this patient is your tympanoplasty with OCR. So I have labeled this patient as safe ear, also known as tubotympanic ear. What is the treatment for tubotympanic ear? Tympanoplasty with OCR. I hope everybody who have revised the notes properly, beta, you are loving the session. Everyone, update in the chat box, beta. All the keywords are being covered. Perfuse discharge, none of the 10 words. Which 10 word I am going to give you? If none of those 10 words and there is a perforation, I label it as tubotympanic ear, safe ear. What is the treatment? Is your tympanoplasty with OCR. What is OCR? Is of two types, PORP, TORP. Partial ossicular replacement prosthesis, total ossicular replacement prosthesis. PORP, TORP. Partial is done for, just remember, partial is done for type 3, total is done for type 4. Total is done for type 4. Woolston classification, again highlight, because this was the last inicet examination MCQ. This can be a potential question of NEET examination. So they will ask you in NEET examination. Woolston classification, they have asked you match the following. So this slide is with you only. One is Austin classification. I am writing some formulas for you. What is group A? Group A is malleus present, stapes present. Group B is your malleus present with footplate present. Group C is only stapes present. Group D only footplate present. Only footplate present. Done. Again, Dr. Satya, beta, incision of serous otitis media is anterior-inferior. ASM is posterior-inferior. Serous is small. ASM is big. Now, this patient is coming with a disease in the upper part. Upper part is your unsafe ear. Unsafe ear, also known as atticoantral ear. Cholestroma is there. Which are the 10 words now? Focus here is very important slide. This is a slide for unsafe ear. This is a slide for atticoantral ear. Atticoantral, very nice response coming in the chat box. Everybody is responding. We are having these 10 words, beta. Revise with me, because on 3rd of March, you have to apply this concept. So we will revise this 2-3 times. All the 10 words in front of you. Ultra fast method to crack the diagnosis of a perforated tympanic membrane. I love the student who are writing everything in the chat box. Very good, beta. Students writing 10 words in the chat box means they have thoroughly revised. Beautiful, beta. This is the best compliment I will say. You have written all the word. How to memorize? Cholestroma lead to scanty discharge. Polyp granulation lead to foul smelling blood stain. And the last 4 words are the upper part of ear. Attic, additus, antrum, par flaccida. Revise with me. Cholestroma lead to scanty discharge. Polyp granulation lead to foul smelling blood stain. The 4 words, attic, additus, antrum, par flaccida. Revise with me. Out of these 10 words, if nothing is there, you will label tubotympanic safe ear. What will be the treatment? Sir, tympanoplasty with OCR. If any of the 10 words are there, you will label unsafe ear. What is the management? Mastectomy. Mastectomy is of 2 types. Canal wall up, canal wall down. What is the advantage of canal wall down? No reoccurrence. Beautiful. No reoccurrence. Here you will be getting reoccurrence. Beautiful. Canal wall down. There is a facial nerve palsy. Here there is no facial nerve palsy. No facial nerve palsy. Which surgery is most commonly done in CSOM? Everyone stop writing. Enjoy the concept. CSOM. MRM. Malignancy. Malignancy. We do radical. If there is a malignancy, radical, modify radical, CSOM. Done. One of the best slide. I will waste my 2 minutes on this slide because I'm expecting this MCQ can be there. I don't know the questions better. It is the experience of last 20 years where we feel this can be the MCQ. This is beautiful tympanic membrane. Enjoy. Beautiful tympanic membrane. This is ante part of mastoid. This is posterior part of mastoid. This is sigmoid sinus. This is the roof. Those who have attended my lecture, your master of middle ear anatomy, my favorite topic. This is my aretus. Now appreciate, my aretus is in the middle ear. I'm going in the middle ear by aretus. On this slide, which two MCQs can be there? On this slide, two MCQs. What is this one? Anyone who reply? What is this slide? What I'm showing you? What I'm showing you? Dr. Saurabh, a very humble request. I can't show you the previous slide. Otherwise, it will not be possible to give you all the concepts. So this video is with you here. You can see later on. No worries. Now concentrate. This is lateral semicircular canal. So one of my brilliant student who say, "Ke sir, anything near, anything below aretus, sir, lateral semicircular canal." Lateral semicircular canal. And what is this one? This is the angle between dural plate, sinus plate. We call it as sinodural angle. What is the name of sinodural angle? Sittelis angle. So they will either ask you lateral semicircular canal or they will ask you Sittelis angle. Sittelis angle. Lateral semicircular canal, Sittelis angle. Coming to the next slide. Very important point. Who is the best friend of ENT surgeon? Alphabet C. Who is the alphabet C? Sir Stipis. Concentrate. Always we take the help of alphabet C. Concentrate on the board. This alphabet C, can you appreciate this one? Focus your eyes. This is alphabet C. So this is how to identify the important structures. Enjoy. This alphabet C is stipis. Anything lateral is ossicle. Anything medial, oval window. So wherever the alphabet C is attached, that is your oval window. So here will be my inner ear. And what will be this? This is round window. So how you differentiate? Your eyes should focus on alphabet C. C is equal to stipis. Medial to C is your oval window. Below C, round window. What I'm showing you, most common complication of unsafe ear, that is mastoiditis. Most common symptom of mastoiditis, discharge. Most common sign is tenderness. Earliest sign is ironing of the mastoid, and hallmark sign is sagging of the canal. Revise with me. Most common complication is mastoiditis. Most common complication of CSM, mastoiditis. Most common symptom, ear discharge. Most common sign, tenderness. Earliest sign, ironing. Hallmark sign, sagging of the canal. Sagging of the canal. Clear? These are the few important abscess which should be on your tips. If there is an abscess along sternocleidomastoid, we call it as Bizold abscess. If there is an abscess along digastric muscle, it is Sittelis abscess. If there is an abscess behind pinna, it is postauricular, which is most common. Postauricular abscess is most common abscess. One student is asking very nice query. I will reply. Donaldson line, beta, Dr. Ashish, just have patience. सब कुछ आएगा, कुछ नहीं छोड़ूंगा, ये promise है. You will not miss a single question. You will inbox me on the Insta on the 3rd of March. Ke sir, all ENT 10 MCQs were from the notes, from DVT notes. That's my promise to you. Clear? Just revise them religiously. Labyrinthitis, which canal is involved? It's a lateral canal. Which part of the facial nerve is involved in CSM? Tympanic part. What is Peter's bone involvement? It's a Grednigo triad. Grednigo triad. Grednigo triad. What is Grednigo triad? Discharge, diplopia, deep-seated pain. Fifth and sixth, now palsy. One of the students is asking me, looks very nice, better. Lux abscess. What is lux abscess? In the external auditory canal. Lux abscess is in the external auditory canal. Fifth and sixth. What is the fifth and 10? Fifth and 10 is Trotter's triad. Fifth and sixth, Grednigo triad. What is the investigation of Grednigo triad? HRCT. Investigation of choice. Because Peter's bone is involved, it is your HRCT. We'll go for HRCT. Done. Diagnosis of last slide. Which slide? This is mastocytitis. Mastocytitis. These are some complication. I take you to the intracranial complication. Expected MCQ. They can show you this slide. They will ask you which lobe is involved. Most common lobe involved in CSM, temporal lobe. Second most common is cerebellum. Just remember this point. Most common is temporal lobe. Second most common is cerebellum. They can ask you empty delta sign. What is empty delta sign? Is a hallmark feature for lateral sinus thrombophlebitis. Empty delta sign. There is a typical feature, fever. Which fever? Sir, spiky fever. What is the name of the spiky fever? Hectic fever, also known as picket fence fever. Spiky fever, picket fence fever. What is Gray-Singer sign? Everybody concentrate on the board. Gray-Singer sign is your edema. Edema over the mastoid. If there is a edema over the mastoid, it is Gray-Singer sign. If there is a edema over the retinal vein, it is Crowback sign. Crowback. Mastoid, Gray-Singer, retinal vein, Crowback sign. What is Tobbe-Ayer sign? Tobbe-Ayer sign is no increase in intracranial pressure, no increase in ICT on pressing the jugular vein. If you press the jugular vein, there is no increase in ICT. That is Tobbe-Ayer sign. Coming into autosclerosis. What is the other name of autosclerosis? Fissure antifenestrum. Why? Because it is most commonly on the anterior focus. It is most commonly on the anterior focus. Therefore, we call it as fissure antifenestrum. It can be on the posterior focus. Enjoy the concept. If the whole circumference is involved, we call it as circumferential. And if both surface are involved, both surface, medial and lateral surface, we call it as biscuit type autosclerosis. If foot plate plus suprastructure both are involved, we call it as obliterative. Obliterative. It is painless, progressive deafness in a pregnant female. The word pregnancy have to be there. What is the voice? Make a concept with me. Conductive patient have a soft voice. Low intensity voice. Sensory patient are shouting patient. Sensory patient shouting. This is not the time to learn why. Just remember, as for sensory, as for shouting, and conductive is low intensity soft voice. And then, and everyone can do this experiment. You close your ear. Now you are suffering from conductive deafness. Speak something, you get a nice perception. Because conductive patient, no disturbance is coming. Therefore, they speak low. Understandable? So, if somebody in your OPD, if somebody is using soft voice, never feel that he is a humble patient. He is a conductive patient. And if any girl feel that her boyfriend is very humble, down to the earth, get his pure tone audiometry done. Am I understandable? These are the few points you should remember. Autosclerosis. Coming to the next one. Paracusis will see. What is paracusis will see? Very nice concept. Every conductive patient feel comfortable in noisy surrounding. Every conductive patient feel comfortable in noisy surrounding. Why? Everybody is speaking loud. Therefore, they feel very comfortable. Clear? Paracusis will see conductive deafness. Mild deafness, listen, this is the need of R. Next 2 months, Jan and Feb, those students who do at this speed, they are in the top 500. Mild deafness, 40 decibel, Carhart notch, earbone gap, Weber lateralized towards ear, Rini's negative. Impedance audiometry is the investigation of choice. Within 1 minute, 30 seconds, you can write all the audiometry finding of otosclerosis. Why? Because this is conductive deafness. Mild, 40, earbone gap, Carhart notch, Weber lateralized towards ear, Rini's negative. Impedance audiometry, conductive deafness. Stepidotomy better than stapedectomy. Drug of choice is sodium fluoride. I will discuss later on. But before that, if they show you the red tympanic membrane, if they show you this tympanic membrane, it is short sign, contraindication to surgery. I will not do surgery. I will go for sodium fluoride. What is this sign? This sign is short sign. Red tympanic membrane, also known as flamingo pink sign. Dr. Soni, beta, foot plate plus suprastructure is which type of otosclerosis? Obliterative. This is double ring sign on CT examination with a cookie bite audiogram. Some students were asking me how to differentiate cookie bite. Cookie bite is a pure tone audiometry. Examiner will give you, study the following pure tone audiogram. If it is assuming a shape of M, that is cookie bite. Study the following tympanogram, that is myopathy. I hope now everything is clear. But if they show you pure tone audiogram, it is cookie bite. If they show you something tympanometry, that is your myopathies. I hope everything is clear. This is cochlear otosclerosis. Cochlear otosclerosis. Listen carefully, enjoy the segment. After this DVT session, next 2 months, you can have the phobia. You can go for multiple sources, add the point, quantitative learning, or a smart student will start revising all the notes. 1 day before NEET examination, which level we have to reach? We have to reach this level. The double word is mentioned in ENT. 1 day before, 2nd March, I ask you, beta, there is a MCQ on the word double in ENT. You will say, sir, I am confident. 3 MCQs are there. If they ask me double density on HRCT, it is allergic fungal rhinosinusitis, double density opacity, and there will be other keyword, peanut butter like mucus. I will attempt allergic fungal rhinosinusitis. Sir, if there is a double ring on HRCT, that is cochlear otosclerosis. And if they mention the word double ring sign on a tissue paper, I will call it as halo sign, that is CSF rhinorrhea. I hope you are getting the message, beta. This is what is need of R. Double ring sign. If the word density is mentioned, it is your allergic fungal rhinosinusitis. Which other the keyword? Peanut butter. If double ring is there on the HRCT, it is cochlear otosclerosis. Double ring on a tissue paper is halo sign, that is CSF rhinorrhea. This level will be achieved when you will focus on revision, beta. Take concise notes, revise multiple times. Coming back to the next segment. What I am showing you electrocochleography on one side. It means I am talking about some Meniere's disease, sensory deafness. If all the what are the symptoms of Meniere's disease? Just remember tinnitus, vertigo, sensory deafness. If all the symptoms come in a reverse order, we call it as Lermoy syndrome. What is Tumarkin's phenomena? Tumarkin's phenomena is equal to Meniere's with ataxia. If patient have ataxia, I will call it as Tumarkin's phenomena. What is diaplicusis? The word di is telling you it is 2 sound. Examiner is giving 1, patient is getting 2. That is 2 sounds are visible. Patient have 2 sounds when source is giving 1. Galatfahmi. पेशेंट को गलतफहमी होती है कि दो साउंड्स आ रही हैं. हैंडबर्ड साइन, एनीवन हु कैन टेल मी व्हाट इज हैंडबर्ड साइन? हैंडबर्ड साइन, व्हाट इज हैंडबर्ड साइन? बेटा व्हाट इज, one student is asking me Tullio's phenomena. Give me 2 minutes, let me complete. Hanbert sign is false positive fistula test. False positive fistula test is known as Hanbert sign. Recruitment phenomena. Recruitment phenomena is a hallmark feature for sensory deafness. What is recruitment phenomena? Is oversensitivity. Oversensitivity is your recruitment phenomena. What is Tullio's phenomena? Tullio's phenomena is a discomfort due to recruitment. Because of oversensitivity, patient is feeling very uncomfortable. That's why he feel uncomfortable in the noisy surrounding. Tullio's phenomena. It is Tullio's phenomena. Done. Enjoy this segment. Recruitment is oversensitivity. Tullio's is discomfort. This is a rising curve of hallmark feature of Meniere's disease. Rising curve. Moderate deafness, range of 60, low frequency hearing loss, no airborne gap, Reen's positive, Weber lateralized to better ear, investigation of choice, electrocochleography. What is the treatment of choice? M for Meniere's, nice concept. M for Meniere's, M for malignant otitis externa, M for medical treatment. The treatment of choice is medical treatment. Before going to the next slide, every student, listen carefully. Nutshell of the game. On 3rd of March, these 4 formulas will help you to crack. Tinnitus, vertigo, sensory deafness. The students who are asking TVS, tinnitus, vertigo, sensory deafness, stop writing. Revise this 4th statement very religiously. Sensory deafness is equal to oversensitivity is equal to recruitment phenomena, and we do some tests for recruitment like SISI, short increment sensitivity index. One student is asking me LFH, low frequency hearing loss. Low frequency hearing loss, already covered in PTA. Every student sitting with me, stop writing in the chat box. Now concentrate on the board. Sensory deafness is oversensitivity, recruitment phenomena, SISI. Neural deafness is showing the phenomena of fatigability, rollover phenomena. And which test we are doing for rollover phenomena? Decay test. Revise with me. Sensory deafness, oversensitivity, recruitment, SISI, short increment sensitivity index. Neural deafness, fatigability, rollover phenomena, decay test. Next formula. Sensory patient feel uncomfortable in noisy surrounding. We call it as Tullio's phenomena. And conductive patient, C for conductive, C for comfortable, they known as paracusis, will say. Last 2 months, you have to crack only the keywords, line diagrams, keyword, SISI. Listen to my words, short increment sensitivity index. You are checking the sensitivity. Short increment sensitivity index. Next important flow chart, everybody should be confident. Tullio's phenomena. Tullio's phenomena is patient feeling uncomfortable in noisy surrounding. This is seen in, what is the differential diagnosis of Tullio's phenomena? One is sensory deafness. One is superior semicircular canal dehiscence syndrome. So 2 important points. What is the differential diagnosis of Tullio? What is Tullio? Patient feeling uncomfortable in noisy surrounding. Sensory deafness, superior semicircular canal dehiscence syndrome. This is the treatment for Meniere's. I have given you the whole flow chart. Dietary modification, 80% of the patient respond with dietary modification. Not responding, I can go for diuretics, steroids. Patient not responding, we go for physiotherapy. What is the name of device? Physiotherapy, Menet device. We call it as Menet device physiotherapy. Patient not responding, we go for endolymphatic sac decompression. One of the students was asking me which line is used for endolymphatic sac. Donaldson line. Donaldson line is used for endolymphatic sac. What is Donaldson line? Line perpendicular to lateral semicircular canal. Better don't ask for the break. This is the last spell where you have to stretch yourself. You have immense potential. And because of COVID and all those things, your comfort level was increased. Otherwise, sir, you people are very hardworking. You enter in the medical college because of your hard work in the 12th standard. So just use that potential, stretch yourself. Clear? Just revise in the last segment. Even I advise to my student, if you can't understand the topic, take a red color marker, make a big cross. Don't touch the topic. Be professional, beta. It should not happen that for one MCQ of that topic, I should lose the two simple MCQs of other topic. It should not be there. And it will come with a timetable. If you make a perfect timetable, 9 to 11, I will do this and complete it. Like by 9, we have to complete ENT. In between, even I am exhausted. But we have to continue now. We have to get some decent rank because we don't want to appear next examination. This is Menet device, beta. Menet device. Menet device. This is Menet device. This is microvic for giving gentamicin, for giving injection of gentamicin, silverstein. Beta, paracusis will see is conductive deafness. Why you are getting confused? Dekho, I have prove with me. I have written paracusis will see conductive deafness. Learn the concept now. Conductive patient feel comfortable in noisy surrounding because everybody speak loud. That is known as paracusis will see. Now this is my Donaldson line. So one student was asking me what is Trotman's triangle. So beta, Trotman's triangle, general surgery, posterior cranial fossa, and Donaldson line is for dear Venus. Absolutely yes, beta. Show must go on. We can't afford losing the game of NEET examination this year, because if we are standing on the borderline, if the government announces a new pattern, beta, it will be big trouble, big trouble. So remember my words, work hard 24/7 and crack this examination. And it is very much possible if you focus on keywords, line diagrams. This is something I'm showing you, ice cone appearance of CP angle. I'm talking about most common CP angle tumor, acoustic neuroma. Always remember which now. Inferior vestibular nerve, more than superior vestibular nerve, more than cochlear nerve. This is something order of the acoustic neuroma. Which are the three approaches? We use three approaches: middle cranial fossa approach, translabyrinthine, suboccipital. Just write important MCQ. Translabyrinthine approach is used for young patients. Can you tell me why it is used for young patient? Because this approach have minimum risk of facial nerve palsy. Minimum risk of facial nerve palsy. We use translabyrinthine approach. Coming on the rehabilitation, how to help a deaf patient. Always remember the golden rule. What is a golden rule? Hearing aid is for conductive deafness. Golden rule, hearing aid for conductive deafness is conductive deafness. This is my BTE. If the examiner show you something like this, BTE, behind the ear. This is BTE, behind the ear. डॉक्टर राकेश आज ही करेंगे, आज ही होगा, चिंता ही ना करो आप. You focus your eyes on the slide. BTE, behind the ear, behind the ear. This is CIC, completely in the canal. CIC, completely in the canal. And this is ITE, in the ear. This is in the ear. This is in the ear. So I'm showing you all the hearing aids. This is BAHA, bone anchored hearing aid. If something is on the mastoid, we call it as BAHA, bone anchored hearing aid. Now the slides which are left are very simple, straightforward. What are the indication of BAHA? Canal atresia, canal stenosis, pus in the canal. Even we use for sensory deafness. Even we use for sensory deafness. Clear? Even we use for sensory deafness. These are parts of BAHA: processor, abutment, and there is some implant. Which implant? Titanium implant. It is made up of titanium. I'm expecting one MCQ. What is the most common complication of BAHA? You write skin reaction. It's skin reaction to titanium. The skin reaction to titanium. Then skin reaction to titanium. If examiners show you contralateral routing, cross, where cross is used if you have profound deafness. And what is the definition of profound deafness? More than 80 decibel. Beta, this is changed. In the past, it was 90. Now we get 80 decibel. Cross. What is bicross? Bicross is cross on the profound deaf ear with hearing aid. Hearing aid on mild deaf ear. On the mild deaf ear, we get hearing aid. Then, clear? Anyone? This is the new implant. We call it as middle ear implant. What do you mean by middle ear implant? Middle ear implant means hearing aid in the middle ear. If we keep the hearing aid in the middle ear, that is middle ear implant. What is the key word? VORP. Beta, we have read PORP, TORP. PORP, TORP in CSM. Here we use VORP, vibrating ossicular prosthesis. VORP. This is VORP, vibrating ossicular prosthesis, used for middle ear implants. If I want to keep, this is a new hearing aid we are keeping in the middle ear, where we attach with the incus, long process of incus. Beta, bicross means cross on one ear, profound deaf ear. That cross will take the signal to left. Left is mild, so we put a small hearing aid on the left side. Again, bicross means cross on the profound deaf ear and hearing aid on the mild deaf ear. That is bicross. This is what I'm showing you, Apley's maneuver. This is topic related with benign paroxysmal positional vertigo. Just worth remembering point, there is no hearing loss. There is no hearing loss. Posterior canal is commonly involved. Calcium carbonate bodies are involved. BPPV, Apley's maneuver. What is the investigation of choice? Is Hall-Pick maneuver. Investigation of choice, Hall-Pick maneuver. Sudden sensorineural hearing loss is loss of 30 decibel over 3 frequencies over 3 days. Over 3 days. The treatment is vasodilator because the most common cause is vasodilator. Vasovascular, because most common cause is vascular, we give vasodilator drugs. Which is the best vasodilator? Best vasodilator for inner ear? Carbogen. What is carbogen? 95% oxygen with 5% CO2. This is fistula test. We press the triggers, we look for vestibular symptoms. Negative in normal human being. If it is positive, obviously fistula is present. But examiner asks you false negative and false positive. What is false negative? Make a formula. False negative means symptom absent but fistula present. False negative means fistula present but symptom absent. It is seen in dead ear or extensive cholestroma. Extensive cholestroma. What is false positive? False positive means symptoms present but fistula absent. What is the differential diagnosis? Differential diagnosis is congenital syphilis and Meniere's. Congenital syphilis and Meniere's. And this is known as Henbert sign positive. We call it as Henbert sign. The false positive fistula test, also known as Henbert sign positive. Done. Coming to the next one, this is which investigation going on? VEMP, vestibular evoke myogenic potential. This is the investigation of choice for vestibule. What vestibule? Then VEMP, vestibular evoke myogenic potential. But the larynx part is a more of visual. This is ear is more of concepts. VEMP is of two types. Everybody is of two types. One is cervical, one is ocular. Cervical is ipsilateral sternocleidomastoid is used here. It is a inhibitory response, and which nerve is responsible? Inferior vestibular nerve. Ocular is extraocular muscles. It is excitatory response, and superior vestibular nerve is involved. What is this diagnosis I'm showing you? I'm making a diagnosis. This one is superior semicircular canal dehiscence syndrome. This is superior semicircular canal dehiscence syndrome. Diagnosis. What is the diagnosis? The patient will have conductive deafness with CNS symptoms. The two important keywords. The keyword for this topic is here conductive deafness with CNS symptom. Always remember, this is superior semicircular canal dehiscence syndrome. Even the word is telling you I am conductive deafness. Investigation of choice is VEMP. Treatment of choice is like CSF rhinorrhea, wait and watch with IV antibiotics. In this, we are having Tullio's phenomena positive, Tullio's, and one is third window effect. What is third window effect? Third window effect is a fistula, so there is a loss of sound energy. Very nice, Dr. Harshita, excellent. The students who are asking to repeat VEMP is of two types. Cervical, I keep on the neck, I keep on the extraocular muscle. Beta, this is electrode number 1. I stimulate the ear. Then I see the reflux in the sternocleidomastoid and extraocular muscle. It is of two types, cervical, ocular. They can even ask you on MCQ, VEMP stimulate which part of the canal. Any student who can tell me which part of the inner ear is stimulated in VEMP. VEMP stimulate saccule. They stimulate saccule. Definitely better. Dr. Raghav, Tullio's phenomena is patient feeling uncomfortable in noisy surrounding. I will write again, no issue. What is the diagnosis of this patient? Diagnosis of this patient is superior semicircular canal dehiscence syndrome. What are the symptoms? Conductive deafness with CNS symptom. Investigation of choice, VEMP. Treatment of choice, wait and watch. Tullio's phenomena with third window effect is your keyword. Tullio's and third window effect. Better don't do this in the last 2-3 months. Don't ever mug up the things. Just make concise notes and revise them again and again. A beautiful topic of larynx waiting for you. More of visuals, better. Larynx is more of visuals, no worries. This is epiglottis, high rise epiglottis visible to you. The epiglottis coming up to base of tongue. Epiglottis coming to base of tongue. Very nice visuals. Papilloma. I make a diagnosis of papilloma. If papillomas are, concentrate on the board, if they are multiple, it is juvenile. If they are single, that is senile. Juvenile are multiple, resolve spontaneously, reoccur spontaneously. Which virus is associated? 11 more than 6. Intubation contraindicated. Treatment of choice, CO2 laser. One drug is approved in this patient, Cidofovir. We know rarely use because it have many complications. What is the beauty of senile? They are single, they never resolve, never reoccur. Clear? Beta, superior semicircular canal dehiscence syndrome, there is a fistula. Therefore, there is a third window effect. Half of the sound energy is not reaching cochlea. Nice query actually. One of the girl is asking, sir, Tullio's was sensory. No, I taught you Tullio's is sensory and one exceptional topic, superior semicircular canal dehiscence syndrome. Why you have tulios in superior semicircular canal? Because sound is irritating the brain. There is a fistula in the base of the brain. Therefore, patient feel uncomfortable. Coming next, what is this diagnosis? Can you appreciate? Nice visuals. I am showing you some turban shape, epiglottis, clue, mouse nibbled appearance. Mouse nibbled appearance. We go in the diagnosis of, yes, anyone? This is your TB larynx. TB larynx. Weakness of voice. Weakness of voice is the most common symptom. Loss of adduction, most common sign. Earliest sign is hyperemia of the posterior commissure. Turban shape epiglottis is there. Pseudoedema. Pseudoedema is due to cellular infiltration. Cellular infiltration. I have two MCQs for you. Knob-like epiglottis is your leprosy, and wash leather, like your wash a leather wash appearance, syphilis. Very favorite question of my TND. Wash leather appearance, syphilis. Beta, next slides are more of visuals. You have to see everything is written. No diagnosis. What is the diagnosis? I am showing you some swelling here, white tumor here in this slide. You can appreciate cricoid. This is somewhere chondroma or chondrosarcomas. Clear? They are commonly affecting posterior lamina of cricoid. Lower margin of laryngeal cricoid that in the arytenoid area is commonly involved. Old age, adult age, there is male more than female. This is something related with chondroma or chondrosarcoma. One of the students is asking me, Cidofovir is a drug of choice for papilloma, not used because of complication. Not used because of complication. But this video is with you only, no worries. Ringkis edema, known as polypoid degeneration. Can you see there is a fluid in the rinky space? What is rinky space? Just beneath the mucosa is rinky space. What is the treatment? Microlaryngeal stripping. Just remember, beta, it is not a pre-malignant. It is not a pre-malignant lesion. Not a pre-malignant lesion. Clear? Coming to next segment. If you get something benign at the junction of 1/3, better listen. No need of writing anything. On investigation, if you write something, on investigation you find there's something on both the vocal cord, it is nodule. What is the treatment for nodule? Wait and watch. What is the investigation of glottic system? Investigation of choice for glottic system is video stroboscopy. Video stroboscopy. Clear? Anyone who can make a diagnosis? There's only one vocal cord involved. Anyone? If it is bilateral, it is nodule. If it is only one vocal cord, it is polyp. What is the beauty of polyp? We have to operate. We have to do surgery. Larynx, more of visuals. I am showing you a intubation granuloma after faulty anesthesia technique, like anesthetist, first year PG student, intubating for the first time, overexcited. Take the endotracheal tube, damage the posterior commissure. There is known as intubation granuloma. Clear? Intubation granuloma. Epiglottic cyst. Always remember, most common site for epiglottic cyst is on the anterior surface, lingual surface of the epiglottis. These are the important areas where patient have epiglottic cyst. Clear? One student, Dr. Sakshi, is asking, what is UPS? Unilateral, P for polyp, S for surgery. Is a mnemonic, actually, we discussed in the class. Unilateral polyp surgery. Unilateral polyp surgery. Beta, laryngocele, there will be an air-filled cavity. There will be radiolucency. Chondromas, you will be getting tumor. Is a tumor of cricoid cartilage. So laryngocele will be opacity. Voice disorders, spasmodic dysphonia. What is spasmodic dysphonia? Listen carefully, beta. Listen carefully. Beta, these are Vivek, beta, they are visuals. Polyp visual, nodule visual. There is nothing to, you can say, right. Therefore, stroboscopy is the investigation of choice for glottic system. Glottic system. Always remember, glottic system is video strobo. Strobo means intermittent light. If you give a intermittent light, flash of light, you will appreciate ultra fine movements of the vocal cord. Beta, vocal nodule on both the vocal cord, polyp on one vocal cord. Polyp is unilateral, nodule is bilateral. Clear? Beta, it will be on histopath, chondroma and chondrosarcoma. They will be giving some histopath finding. Clear? They both involve cricoid cartilage. Coming to the next one, voice abnormalities. We have spasm, abnormal voice. Muscle is in the spasm. Which muscle? One student is asking me how to differentiate vocal nodule from intubation granuloma. Beta, intubation granuloma is always on the posterior part of the vocal cord. Or polyp and nodule, they are at the junction of 1/3, 2/3. This is a nice point. This is my vocal cord. If you get something at the junction of 1/3, 2/3, that is polyp nodule. If you see something behind, it is granuloma. This is something we discussed in the basic point. Spasmodic dysphonia, adductor muscle spasm. If adductor muscle are in the spasm, we get strangulated voice. We see effortful voice. And abductor is a weak voice, breathy voice. Breathy voice. What is the treatment? Botox injection. What is phonesthesia? Weakness of muscle. So we are having 6 MCQs. If thyroarytenoid is paralyzed, you will get elliptical image between the vocal cord. Right and left vocal cord will assume as elliptical. And if interarytenoid is paralyzed, it is triangular appearance. If both are paralyzed, it is keyhole appearance. It is keyhole appearance. Done. What is the treatment for phonesthesia? Is complete voice rest. Complete voice rest. Faulty use of false vocal cord. If patient is using, very simple here, no hi-fi things, faulty use of false vocal cord. Patient is using false vocal cord is known as dysphonia plica ventricularis. Nice query. Dr. Mohit is highlighting very nicely. Okay, there will be history of intubation, then you will attempt intubation granuloma. Very nice point. Clear? Better, Dr. Arpit, it's my responsibility to entertain all the doubts, but I'm trying my best. Okay, it should not interrupt the speed of the lecture. Mogiphonia. What is mogiphonia? Is abnormal voice in public. Very good. What is the key word for dysphonia plica ventricularis? Mimicry. The child have a habit of doing mimicry. We call it as dysphonia plica ventricularis. What is the diagnosis? Anyone? Any student who can make a diagnosis? Nice slide. A female having a voice like male. Androphonia. We call it as androphonia. Any student who can write in the chat box, what is the treatment for androphonia? Is here. Anyone? Treatment for androphonia? Androphonia, type 4 thyroplasty. Type 4 thyroplasty. Type 4 thyroplasty will be androphonia. Done. Anyone who can make a diagnosis? In your OPD, a mama's boy come, low pitch voice in a young boy, 14-year-old boy, low pitch voice, over dependent boy on the mother, over dominating mother. This boy, mama's boy, puberphonia. This diagnosis going in the favor of puberphonia. Is puberphonia. What we do, we push the thyroid inside and pitch become normal. Gutsman test. What is the name of the test? Gutsman test. Push the thyroid inside, pitch become normal. When you revise 4 or 5 times, you will say child neither have the guts nor he is a man, but test is known as Gutsman test related with puberphonia. Gutsman test related with puberphonia. No. We will not do type 3 thyroplasty. We'll give psychotherapy. This is over dependent on his mother. Psychotherapy. Psychotherapy to the child. Some students in Viva, they say psychotherapy to the mother. No, mother is over dominating. She will not change. Psychotherapy to the child. What the psychiatrist will teach? Psychiatrist will teach, okay, beta, you're becoming adult. No need of asking anything from your mother. You should ask everything from your girlfriend because you are getting adult. After psychotherapy, he is now absolutely fine. Am I understandable? So what is the treatment for puberphonia? Is psychotherapy. These visuals you will never forget. So after psychotherapy, now he's confident. He's not picking his mother's call. Clear? Comfortable? Coming to the next level. Unilateral recurrent laryngeal palsy. Make a golden rule. Make a golden rule. Make a golden rule. Beta, this slide will be missing in book here. How can you see why I should give this slide in the book? Yes. Concentrate on the board. Unilateral recurrent nerve palsy is normally asymptomatic. Hoarseness. No treatment. Wait and watch. What is the treatment for all unilateral cases? Is wait and watch. Wait and watch. Beta, type 3, I will explain. Type 3, where is it? So give me few minutes there. I will not miss anything. जब मैं यहाँ तक पहुंच गए तो बहुत कम बचा हुआ है. Bilateral recurrent nerve palsy. Patient have severe dyspnea. Last neat examination after head and neck surgery. Patient have severe dyspnea. What to do? Which complication occur? Bilateral recurrent nerve palsy. What is the treatment? Treatment is tracheostomy or lateralization procedure. Lateralization. If the patient have unilateral superior laryngeal nerve palsy, this is expected MCQ. SQ appearance. SQ glottic. SQ glottic is seen in unilateral. This is very important concept, important finding, should be on your tips. Weak voice. Patient have weak voice. Again, wait and watch. Beta, always remember, in all unilateral cases of paralysis, we prefer to wait and watch. We always prefer to wait and watch in unilateral cases. If it is bilateral, superior laryngeal nerve palsy, aspiration. Superior laryngeal nerve palsy means aspiration. Beta, Boeing matlab, SQ word we use the word for Boeing. It is typical word is used in the textbook. Boeing of the vocal cord. So main symptom is aspiration in this case. I'm again revising for you. Stop writing. Unilateral recurrent, only hoarseness. Wait and watch. Bilateral recurrent, dyspnea, tracheostomy. Unilateral superior laryngeal nerve palsy, again hoarseness, wait and watch. Bilateral superior, go for tracheostomy with epiglottoplasty. Close the epiglottis. Why? Because patient is aspirating. Position of the vocal cord, beta, median, paramedian for voice, and gentle abduction, full abduction is for respiration. I have 4 type of thyroplasty. Type 1, medialization. Where we are using medialization, we use for bilateral superior laryngeal nerve palsy. Type 2, lateralization. It is used for recurrent nerve palsy. Type 3 is relaxation. And type 4 is lengthening. Type 4 is androphonia. And type 3 will be resistant case of puberphonia. Very resistant case of puberphonia. Done. Cadaveric position, beta, is a question of viva. They will not ask you, I promise you. Coming to the next segment, what is this voice disorder? Can you identify? Young female, history of break off with the boyfriend. No voice, but cough is normal. What is the diagnosis? This is known as functional aphonia. Functional aphonia. This is the diagnosis of functional aphonias. The female, deliberately she is not speaking out because of some mental trauma. Young female, which mental trauma? So history of breakup with the boyfriend. Treatment, again psychotherapy. After psychotherapy, what psychiatrist will teach her? Psychiatrist will teach her, beta ek gaya, dusra aayega. You are from India, most populated country of the world. So don't take so much pressure. Emotional student never get good rank, beta. Next 2-3 months, don't get emotional, be practical, be professional. So after psychotherapy, now this female is absolutely normal. Am I understandable? So what is the treatment for functional aphonia? Psychotherapy. I hope you will never forget. Again, I can't give this slide in your books. Coming back to the next topic. Larynx. Carcinoma, larynx. Important points. T1, T2, T3, T4. T1, only 1 subunit is involved. T2 is 2 or 3 subunits are involved. But even later on, you can appreciate all these slides. No worries. T3, these are the 5 important P. I give in my lectures 5P. But it is 9. Now you will give me a return gift. You will give me few minutes. Let me complete this nicely. 5 P's are there. T3. But we complete the whole ENT. I promise you. As a faculty, I am telling you, I have not missed anything which is not important for your exam. I have completed each every point. I have not missed a single point. Clear? Just revise it again and again. Paraglottic space, pre-epiglottic space, pharynx, perichondritis, paralysis. That is for T3. That is for T3. T4A is your tongue, trachea, neck muscles. T4B is chest, carotid artery, prevertebral space. What is the management part? This is important slide for the management part. Carcinoma in situ, CO2 laser. T1, T2, we go for radiotherapy or partial. Always pray God that MCQ should be from T3, T4. Better last few slide, everything is written. Everything is written. You have to just revise. T3, T4 is total laryngectomy with radiotherapy. But if the patient deny, I will go for concurrent chemoradiation. Concurrent chemoradiation if the patient deny. This is HPL, horizontal partial laryngectomy. I have given everything because I know at this point you are fully exhausted. What are the indication of HPL? Supraglottic tumors. Important expected MCQ for your NEET examination. Which investigation is mandatory? Pulmonary function test. Pulmonary function test is mandatory. PFT mandatory. VPL, vertical partial laryngectomy. I have given you few indication, but on the top I am writing this slide is for inicet. It's NEET examination. They will not ask you the question on VPL. Just remember this point. They will not ask you this question. Clear? Coming to the next point, vocal rehabilitation. How the patient can speak out. So we have some electrolarynx. We have some device with which the patient, vibrator with patient can speak out, or we have tracheoesophageal prosthesis. So this is Blom-Singer tracheoesophageal prosthesis. These are voice button where we fit between posterior wall of trachea and anterior wall of esophagus. We put this prosthesis. Just remember, last NEET they have asked you one MCQ. If you remember this, they have shown you some opening on the neck. On that opening, there is a small opening on the posterior wall. So big opening on the anterior wall, that is for tracheostomy. And small opening on the posterior wall, that is for tracheoesophageal prosthesis. So this, which surgery was done? This is after total laryngectomy. After total laryngectomy, we use tracheoesophageal prosthesis. I am expecting one MCQ on this topic. Better they can ask you polite yawning, because this was inicet MCQ. So this can be potential. Polite yawning. What is polite yawning? We teach to our patient after total laryngectomy. Polite yawning is yawning with closed mouth. When you yawn with closed mouth, the air will go via nose. It helps in the olfactory refunctioning. Olfactory refunctioning. Then, beta, it is placed on the posterior wall of trachea. You have removed the larynx after total laryngectomy. These slides are important. Clear? Polite yawning used for olfactory refunctioning. Tracheostomy, very important topic. I have few important points. Which tube is most commonly used? Cuff tube. This tube is most commonly used. Fenestrated tube is used for voice. Fenestrated tube is used for voice. Beta, tracheostomy tube will be on the anterior wall of trachea, and tracheoesophageal prosthesis will be on the posterior wall of trachea. One liner on the top, everyone should write 3rd March. One MCQ from these questions. इतना confidence कोई भी नहीं देगा आपको. Out of these, one MCQ. Which is the best site? So 2nd to 3rd. We give the answer. Cuff tube, so necrosis. How frequently we should deflate the necrosis? So too early for 5 minutes. Tracheostomy tract is formed within how many days? So 7 to 10 days. What is the most common physiological complication? Such CO2 washout. What is the most common complication? So bleeding. Vertical tracheostomy is done for emergency. Horizontal, sir, elective. High level for malignancy. Low level for infection. Total blockage, remove it. Partial blockage, do suction. Revise with me. Now don't ask any query, because 2 months before the examination, these points should be on my tips. Low level, done for infection. Why? Forget beta. High level, malignancy. Low level, infection. Total, remove it. Partial, do the suction. This speed at which we have completed these MCQs, you should complete it. You should revise the topics. I hope you're getting them. message. This is a motive of DVT beta, to give you a momentum. We want to give you a momentum at this point. And if you, next 2 months very crucial, either you can go in a slow manner or you can go in this. Coming to the next one, Montgomery tube. Montgomery tube. Beta, CO2 washout. You give an insane whole CO2 come out. That is CO2 washout. Patient land up with apnea actually. Montgomery tube is used for bronchial stenosis. Montgomery tube used for bronchial stenosis. These are the 4 findings. Laryngopharyngeal reflux. I have given you. You can read subglottic edema, glottic edema, ventricular obliteration, and one is PCH. They can ask you the full form. What is PCH? Posterior commissure hypertrophy. Posterior commissure hypertrophy. These are the findings. These are the important keyword for angiofibroma. Every student sitting with me across the country, revise. In young males, 14-year-old boy, epistaxis, most common site, sphenopalatine foramen. Overexpression of IGF2 is found in juvenile nasopharyngeal carcinoma, inicet point, but revise for neat. Which is the non-invasive approach? Non-invasive, I am writing non-invasive, endoscopic transnasal. Which approach is used for small size tumor, such transpalatal? Recurrent epistaxis, unilateral progressive obstruction, Holman-Miller sign, surgery but no biopsy. Which artery we embolize? Internal maxillary artery. MRI for extension. Again, on the top of this slide, write 3rd March. 1 MCQ from angiofibroma. There is no NEET exam. They have not asked anything about 3rd March. Clear? I hope you are loving these points. These are the key word at this point of time, beta. Don't open angiofibroma. 10 pages are there. Just focus on the keyword. Even if you have attended my live lecture, we have completed angiofibroma in 10 words. Nasopharyngeal carcinoma, Chinese population, Epstein-Barr virus. Chinese population, Epstein-Barr virus is nasopharyngeal carcinoma. What is the age of distribution? 20 years, 50 years. I hope you will never forget. It is bimodal distribution, 20, 50 years. Coming next, fossa of Rosenmuller, most common site. Type squamous cell carcinoma, Epstein-Barr virus, which is the most common presentation, unilateral cervical lymphadenopathy. Trotus triad, what is trotus triad? Glue ear with 5th and 10th nerve palsy. Glue ear, 5th and 10th nerve palsy. Then I hope you will never forget all these slides, everyone. Each and every slide will help you and you will remember me in the examination hall. You will remember me in the examination hall. Coming to the next segment. Tonsillectomy, sir, rose position. Dissection and snare method is the oldest method which we commonly use. Diathermy, what is diathermy? We use high temperature, 150 to 400. Everything is given on the slide, no worries. These are different methods of tonsillectomy. These are different method of tonsillectomy. Done. In the Telegram group, you will tell me beta, which slide was the best. Clear? Which was the second best, which was the third best. In the Telegram group, after 9, 10, we will discuss all these points. We are on the verge of completing. These are different method of tonsillectomy. Don't take the pressure, beta. Cryosurgery. What is cryosurgery? I have given all the keyword. Use CO2 laser. Just give 5 minutes to a slide. You will be microdebrider, internal intracapsular microdebrider. These are method of tonsillectomy, beta. Method of tonsillectomy. If they show you this device, this is 45-degree handpiece for microdebrider. Ultrasonic vibration. This is expected MCQ. Ultrasonic vibration used to damage the tonsil. What is the method? Harmonic scalpel. What is cobaltation tonsillectomy? We use a temperature of 40 to 80 to do tonsillectomy. These are the important slides. Whether these 2 slides important for different method of tonsillectomy. Expected MCQ. Tonsillectomy done. Patient was normal, no bleeding. Patient shifted to recovery room. Patient start bleeding. Which hemorrhage? Sir, reactionary hemorrhage. What to do? Sir, shift the patient to OT. Religate the patient. Expected MCQ. It's clear. Be a game changer, beta. 2 lakh students are there. Many players are there. But take my word, be a game changer. Learn from them. COVID was difficult for us. But now we are again on the top. auditorium is full house full, more than 2,500 students attending the face-to-face session. And take my words, beta, the speed at which we have learned last 3 hours, if you follow this speed in the next 2 months, you are on the top of the game. Be game changer, beta. Ek yaad rakhna hai, remember one point, when you were in 12th standard, most of the students from non-medical background, the day you enter the medical college, that was a game changer for your family, your whole family. The scenario was changed because you enter in the medical college, and just have the same attitude. Be the game changer in the upcoming one. Damsonians never quit, beta, never quit. They always win the match. So this is the success strike rate of DAMS for the last 20 years. We are teaching to our students qualitative learning is the best. Don't run with the quantity. Don't have the phobia. Anything will be missed out. Nothing is missed out, beta. Just revise whatever our faculties are teaching in DVT session. More than sufficient for getting a decent branch. And again, take my word, beta. If I ask you which is the least important factor in your life, is your NEET PG examination. Your family, your parents, your own life is on the top. This examination is just 1% of your life, beta. ज़्यादा importance नहीं देनी इस exam को. It is 1% of your life. So be mentally very strong. Best of luck. All the best. You can ask me all the queries on my Insta ID. You can inbox me. Share your feedback. I'm giving you my WhatsApp number. I want your feedback on this WhatsApp number 7837536346. Thanks for all the wonderful audience and the way you were responding in the chat box. It means you have revised the notes properly. Clear? Repeat Prusek space. Prusek space is a space between pars flaccida and malleus, is the most common site for colostoma formation. Most common site for colostoma formation. I'm waiting for you for your interview in this studio from where we are taking these DVT session. And I want everybody who is doing a very sincere effort should be on the other side of the game. Thanks a lot. Best wishes.